knowledgeable about early diagnosis and treatment and follow-up of those patients with pneumonia. Keeping the adequate provisions of antibiotics and system is and will be a challenge. However, we're working relentlessly to keep both antibiotics and oxygen adequately provided in the healthcare system. Let me thank you all for your contribution, and I can assure you that you all have the support of the Ministry of Health. Muchas gracias.
Now we have words from Dr. Jarvis Barbosa, Director of the Pan American Health Organization, PAHO. Go ahead, Dr. Barbosa.
Esteemed Dr. Joaquin Barnoia, Minister of Health, Dr. Núria Chaves Salazar, Dr. Julio Tejada, esteemed colleagues, partners, and friends. It's a privilege to join you today at this 50th Global Conference for World Pneumonia Day. On behalf of the Pan American Health Organization, PAHO, I extend warm greetings and appreciation to the organizers and partners who have made this event possible. World Pneumonia Day is not only symbolic, it's a call to action. Pneumonia remains the leading infectious cause of death among children under 5 years of age worldwide. In the Americas, we continue to lose more than 20,000 children every year to a disease that is both preventable and treatable. This burden falls disproportionately on the poorest and most remote communities, where timely diagnosis, oxygen therapy, and effective antibiotics remain out of reach. Nonetheless, the impact of pneumonia extends beyond childhood. Older adults, people with chronic diseases, and those living in vulnerable conditions are also at high risk. This year's theme, Enhancing Diagnosis, Managing Oxygen Needs, and Tackling Antibiotic Resistance, is central to reducing pneumonia mortality. In this regard, PAHO is working to expand the access to pulse oximetry and oxygen therapy at surveillance and laboratory capacity to detect respiratory pathogens, implement national plans to address antimicrobial resistance, and promote integrated child health strategies that include immunization, nutrition, and timely care. It is also important to highlight that innovation is open doors to new ways to detecting and managing pneumonia. The use of artificial intelligence to optimize X-ray detection, molecular panels that can identify bacterial or viral infections within hours to enhance clinical decision-making, telemedicine, portable ultrasound devices for areas with limited access to radiographic services, metagenomic diagnostics, and digital platforms supported by sensors are expanding access to fast and accurate care, even in low-resource settings. Allow me now to continue in Spanish. Existem outras medidas inovadoras, como as vacunas conjugadas de nueva generación que ampliam a cobertura contra serotipos emergentes e o surgimento de novos antibióticos para combater a resistência bacteriana, junto com o uso de terapias imunomoduladoras que apoiam em reduzir dano inflamatório e melhorar a recuperação. Cabe destacar que a Organização Pan-Americana de la Salud, OPS, vem impulsando o acesso às tecnologias já mencionadas através de nossos fundos estratégicos e para acesso a vacunas, como os kits de telemedicina e a vacuna Valente contra pneumococo de produção regional. O contexto atual da saúde global e regional requer que sejamos dinâmicos para adaptar-nos a um entorno que traz novos retos, alcançar novos ritos em la prevenção, diagnóstico e tratamento de las pneumonias e propiciar que as inovações estejam ao alcance de todas as pessoas. Esse esforço dependerá de um trabalho articulado com a participação de todos os atores e sócios que, por sua visão e dedicação, são fundamentais para garantizar que nossas populações não se quedem atrás em el acesso equitativo à atenção em saúde com qualidade. Em nome da OPS, reafirmo nosso compromisso de trabalhar junto aos países das Américas para reduzir a carga da pneumonia, fortalecer os sistemas de saúde e garantizar equidade no acesso à prevenção e ao tratamento. Que esse Dia Mundial de la Neumonía sea um recordatório de que nadie deveria morir por uma enfermidade que sabemos como prevenir e tratar. Muchas gracias.
Taking care of lungs, promoting vaccination.
Thank you. And now,
Distinguished colleagues, health authorities, special guests, and friends, today we gather together to commemorate the World Pneumonia Day, a day that invites us not only to remember but to reflect on a disease that continues to pose both a global and national challenge, a disease that, despite medical and technological advances, still claims lives. Lives that could often be saved through importance of strengthening our respiratory care system, improving access to vaccination, and educating our population about warning signs and prevention. From the Guatemalan Association of Pulmonology and Thoracic Surgery, we reaffirm today our unwavering commitment to the respiratory health of Guatemalan people. Our work goes far beyond treatment. It means educating, research, and preventing. It means joining forces across public, private, and academic sectors in a shared effort to reduce the burden of pneumonia and to improve the quality of life of our patients. Vaccination against pneumonia and influenza, the control of risk factors such as smoking, and the early detection of respiratory infections must remain pillars in our public health policies. But we must also remember that behind every case, there's a human face, a story, a family who place their trust in us, the health professionals. Today, I wish to recognize the tireless and often unseen work of physicians, nurses, respiratory therapists, and all healthcare personnel who confront the disease every day in hospitals and clinics and community centers through the country. You are the heart of this effort, and your dedication represents the essence of our professions, to serve with science, compassion, and commitment. May this day remind us that pneumonia can be prevented, treated, and overcome if we work together with empathy, knowledge, and determination. As president of the Pulmonologists Association and Thoracic Surgeons, I invite all of you to continue being active participants in this collective mission. Let us keep educating, inspiring, and building a healthier Guatemala, one that values and protects our lungs. On behalf of the Guatemalan Association of Pulmonologists and Thoracic Surgery, I express my deepest gratitude for your presence and for your commitment to this cause. Let us continue forward with hope, with purpose, and with the conviction that every action we take can save life. Thank you very much.
Thank you. Thank you very much, Dr. Tapia. And now we are going to start with our academic program. And the first part of the program is going to be dedicated to advances in pneumonia diagnosis, tools, technologies, and global access. Our first speaker is going to be Dr. Kevin Baker, an international consultant, and he is going to be speaking about assessing devices for community pneumonia diagnosis. Dr. Baker, please, the microphone and the web is yours.
Thank you very much. There's quite a bit of echo on the line. Oh, that's better. Okay. Thanks so much. Thanks so much. Thanks so much. Thanks so much. I'm going to start. So, technologies, often we won't actually use those diagnostic technologies we have available to us, or and instead we'll make a subjective assessment because we don't trust the technology and we know the technology doesn't work, or we don't have it, it's not available to us. And so those are some of the challenges in relation to diagnosing pneumonia and why we are where we are today. So how are we, all of us, diagnosing pneumonia, particularly in frontline settings and in relation to community settings and health workers and community health workers? So you see here the diagram, a picture of the ARI timer. This was the first pneumonia diagnostic that was developed and introduced by WHO and UNICEF in the 90s. And it is currently the gold standard. It basically is a timer. It counts 60 seconds to allow the health worker to count the breaths of the child over 60 seconds. And that's a common adult child based on the guidelines. And so this is, you know, notionally quite easy, but anyone who's done it will realize that there are inherent challenges with counting a breath for 60 seconds and not losing count, and ensuring the child is calm and still, and lots of other factors that influence and potentially impact on getting a correct respiratory rate measurement. And this is our gold standard that should be done by us all every time we see a child presents that has cough or difficulty breathing. Okay, so these are the challenges that we've seen in relation to how pneumonia is diagnosed and how and what happens. I just want to take a step back now and think about diagnostics. So here you see a diagram. On the right-hand side, you see the egg, which basically shows a diagnostic development pathway. This is really the pathway that typically diagnostic devices follow as they're developed. So we start in the middle of the egg in the white circle, where we look at the technical performance, and then we go from there and then look at acceptability and then thinking about at scale. See here is the defined process, and that each will take a time. So for that initial preclinical, it can take 12 to 18 months. Performance can take another 12 to 18 months. Acceptability and usability can be done with performance, but again, it's another 6 to 12 months if it's standalone. And obviously scale up and rollout can take a significant amount of time. So what this means from a diagnostic point of view or from an individual device point of view is that it takes a lot of time and to actually launch a diagnostic product. So it's several years and millions of dollars to get a device from developing and evaluating the technical spec of the device to actually launch in the field. And that means that, you know, because of these multiple stages, it's really a complex and expensive process to develop a diagnostic tool, and one that is fraught with challenges and different steps along the way that can prove challenging to develop a diagnostic. So now let's think about how this relates to pneumonia. Across the top there, the different arrows, that's just basically another way of displaying the steps in bringing a device or diagnostic device to scale. And the little diagram in the bottom there with the arrows is really just a time scale in relation to pneumonia specifically. So as I said, in the 90s, the WHO and UNICEF developed the ARI timer, which is a manual counter. It's very, very simple. And that was developed and released at scale, tested and released at scale, millions and millions of these in the systems across the world as we speak, and have been distributed for 35 years now. In 2012, the global community, decided or had discussions about improving pneumonia diagnostics, given 100,000. It was felt that a lot of the diagnostic element of pneumonia, and therefore over the subsequent 20-25 years, a huge amount of effort is going to developing and evaluating new diagnostic tools, starting with the work that we did in 2014 at Malaria Consortium with the Gates Foundation, where we tested 9 diagnostic tools in 4 countries. UNICEF also, alongside that, published a target product profile of what an automated, improved pneumonia diagnostic should look like, and used that to test 2 further tools in the field in Ethiopia and Nepal. And subsequently, they then went on to test at large scale some of those devices. We then had multiple other investments in the last 5 to 7 years. Unitaid had large investments with 2 partners where they tested up to 6 devices in multiple countries under the TIPSY project. There was the Aspire study that also looked at various technologies in the field. And currently, the Respire project is continuing to look at new technologies in this space, particularly in Asia. So lots and lots of investments, lots of activity, lots of studies, lots of development. Also, the area study there, top, which is looking at AI. Go into so much detail, but I think I wanted to highlight technology that some of the key of these studies in time. So the list, but it's just diverse that were evaluated inside of the ARI timer again manual. The picture of the numbers above it, that there are multiple counting apps that exist on mobile phones, and then to tap of the child, that is a charm device, which an auto which uses accelerometry, strap the device the child, and it measures the respiratory rate. And on the 6 devices which tested through TIPSY, a range of some of them do some basic technology. Some of them also do temperature devices, but a range of technologies that have been tested over the last, say, 12 years. Learned from all of this development. Unfortunately, I think Frank and I, the new so I think across all of the studies is we had performance from the various on. And it was difficult to show that there was an improved performance for one device at scale. So in no study did we really see a clear winner. Did we see clear evidence that the performance of a particular device was significant? And certainly we didn't see any clear health impact. So it was difficult to show impact of any of the new diagnostics at scale. And therefore, really, we didn't have a complete development pathway. As we saw in that previous diagram, we never, so there is no device scale that is able to replace the ARI timer from the 90s. And there's a range of reasons for this, and I just wanted to highlight some of these and then go on to talk about kind of the learnings and how we apply these and what's important. Because I think, it's really important for us to reflect on these studies and take the learnings and really think about how we pivot and how we use those in the most efficient way going forward, given that we've had 15 years of evaluating technologies. So I think one of the things over the time is around the evaluation methods. So it's, this is notionally quite an easy concept here. Measuring, and surely that's easy to evaluate. And as new technologies come on, we should be able to have a robust evaluation framework that we could use to test the different technologies, no matter what the underlying technology in the diagnostic tool is. However, that's not true. What we've seen over time is that the evaluation methods need to really reflect the technology that's being used and the way that it's measuring the breath and the way that it's measuring the respiratory rate. So it needs to match the technology, and it needs to reflect the specifications of that technology. So it needs to measure the same time period for the respiratory rate so that it matches the measurement that the new device is calculating, and it needs to in some way measure respiratory rate in the same way. So there's a huge amount there. I'm just highlighting a couple of points, but that has been years and years of work to really understand the evaluation methods, and connected to that is the reference standards. So what we measure these devices against must be comparable, must be measurable, absolutely head to head. And we need to ensure that our reference standards that we use to measure the performance of these devices are robust. Cost is another huge a driver in the development pathways. It's something that has meant that we have had real challenges in bringing devices to scale because they've run out of money, because they haven't had the resources to implement the learnings that we've seen in the various stages of the development process. And basically they haven't been able to continue through the development pathway because of cost. Also, the cost of the actual unit cost of the device is obviously a driver, but actually in the development pathway, it's not so much. That's something that is really about when you get to scale. In this instance, I'm really talking about how expensive it is to bring a device through the various stages in the development pathway. We've seen some issues around usability and reliability where devices have got to a certain stage in the process of being evaluated and fallen over. The batteries don't work, some of the usability isn't suitable or is incorrect. The reliability means that perhaps the batteries fail or some other piece of the kit does not stand up to the requirements in the field. Likewise, with acceptability, we found that there are issues around language, around color, around usability, around sound, very basic things that these devices, if not picked up, it can really impact the development pathway for these. Okay, so that's a very quick run through. I think now think about is, so what? What do I think? We must lose hope. I think we haven't, and I think we try that in the most. And that's why the first thing that I think we really need to be pushing for is redesigning the way for efficiency. Over the years, we built this, how we should ideally develop. This has often been developed in relation to for companies with huge development. Does not work in our settings and for our requirements. So I think we do really need to think about redesigning the development pathway to be efficient. So why can we not take devices into the field at the very beginning of the development process so that we really robustly test usability, acceptability, and robustness, and at that early stage before we go through and prototype and build out specs that actually subsequently fail, because that is a huge development cost and an unnecessary one. So I think we really need to think about how we can redesign the development pathway to be the most efficient we can be for our settings and for our needs. We've done a lot of work on improving the evaluation methods. I think we need to publish this. I think we need to be very collegiate in the way that we share this learning, and we all agree on what the evaluation method should be for these diagnostic tools and how we can be the most efficient possible in evaluating these devices and the most robust. And so in our group at Karolinska, we're just publishing some great work on reviewing reference standards and how and what best practice could look like in relation to reference standards. And this kind of work, I think, is super important, that we are very transparent about how we should be evaluating these devices. We also need to think about, so it's really important as we design the evaluations for these devices that we think about and we frame solutions using a systems approach. So if we're evaluating a diagnostic at the happening up, if we're referring those patients up the line and we haven't figured out about treatment and care at hospital level, etc., then how can we show impact? We can't, because it will fall over. So we really need to think about a whole systems approach and how we can ensure that our outcomes are robust and we can report against them in the correct way. I want to just talk about, there's lots of discussion, potential technology, new technologies being introduced. We've seen technologies that have been used in the past being introduced. Here on the left is the Tron device. Exciting to see that happen, and I think this learning to we understand, etc. And I think about scaling these devices. But there you see image work that's ongoing. This is looking at AI-assisted respiratory measurement. Super exciting. This is using video technology to create, and we're seeing some interesting findings on this. This technology is really good. Again, going back to the first point here, I think we need to think about how we can redesign development pathways. So we're testing the usability, acceptability, and robustness of this technology early on, and redesign the development pathway to ensure that we fully understand the utility of new technologies like AI before we go to scale or before we move along the development pathway and come a cropper later on some basic things like language, color. My presentation. Thank you very much. I'm very happy to. And today, thank you for. And yeah, thanks so much. Have a good conference.
It's a very interesting topic. Next, we are going to transition to optimizing oxygen therapy, addressing global gaps in access and delivery. So for the very first topic, which is the Lancet Global Health Oxygen Commission, Dr. Karina King.
Hi, thank you so much. Let me just share my screen. Yeah. I hope you can see that okay. Thank you so much for having me today. It's really a pleasure to be invited to speak at the World Pneumonia Day, and especially to present the keynote findings from the Lancet Global Health Commission on Medical Oxygen Security. We published this report in February, and it's been a huge pleasure to come to different regions of the world to share our key findings and hopefully to mobilize some action behind the recommendations. So I think in the pneumonia world, we were very well aware of the challenges around access to medical oxygen. Most of the research in this area around gaps in access and challenges have come from the pediatric pneumonia space. And when COVID-19 happened, this issue really on I think, sorry, I have to apologize. And it was really a testimony that the global response managed to raise $1 billion for oxygen investment specifically. But I think the way in which this was done kind of highlights some of the challenges that we had faced in the pneumonia field. Oxygen was not initially included in that Act A response, and it took a lot of mobilization from CSO organizations and advocacy in order to get it on the agenda during COVID. And I think that really speaks to pneumonia having been behind the scenes for a long time heard. So it was that we decided to launch the Lancet Global Health Commission on Medical because we really saw this as an opportunity to finally center this topic on the global stage. And as many of us in the room will know, oxygen therapy is not only with acute illnesses, but it's also life-sustaining for those undergoing surgery and also for life-enhancing for people with chronic respiratory failure. This is something that's required across the life course, and it's not only an essential medicine, but an essential service that requires a health systems approach to tackle. And that's the lens with which we decided to approach it in the commission. So I'm going to take you through our key from the report. Oxygen need. So every year, we estimated that 374 million people are in need of medical oxygen, and the majority of these live in low and middle-income countries. During emergencies, the need for oxygen can rise exponentially. During COVID-19, an additional 54 million people required oxygen in 2022 alone. That breakdown, the highest oxygen and followed by sub-Saharan Africa and then Latin Caribbean, with a total of 4.6 billion cubic meters annually. And about 1/4 of that is for acute medical and surgical needs. There's a much larger volume of oxygen required for chronic conditions, even is much smaller. In this, we're going to focus more on the acute conditions under which respiratory infections sit. So when we look at acute conditions in 2021, and the data we used for this was based on the Global Burden of Disease, which launched their 2021 data to include COVID-19. One, for COVID. These are for all the respiratory infections. The needs are particularly for chronic, but less so for and I think to reiterate points that were made earlier about prevent the need for oxygen in the first place should be a key policy goal for all regions. Specifically for pneumonia, that means improving air quality, increasing access to immunizations, especially with the new RSV vaccines giving such successful results in countries where they've been rolled out, prioritizing rollout and scale up of RSV vaccination, reducing childhood malnutrition, and improving water and sanitation. All of these will medical oxygen in the first that act. In terms of that access gap, at the moment on a global scale, less than 1 in 3 people who need oxygen for acute conditions receives it. This is a far higher treatment gap than we see for other in TB. That gap is higher in acute medical conditions, so 22% require a medical condition compared to 3 and 4 for the This gap occurs at multiple levels. So that gap of oxygen not present there, that gap is far outweighed by the health system's readiness to provide oxygen. So the readiness gap is facilities that have the equipment and the capacity to detect oxygen and then provide it with quality care is the last one. And that gap in the cascade differs. The largest gap seen in the where 91 patients in need of acute quality medical oxygen services. It's next highest in the South Asian region, where it's 78%, followed by East Asia, then Latin America and the Caribbean. That doesn't paint the whole picture, however. We also found inequities within systems. So not only between regions, but within facilities in countries. There were 3 times lower access in the urban and in public communities. And the general pattern we've seen for pediatric pneumonia is that the majority of presentations occur at rural public facilities where the access gaps for medical oxygen and access to pulse oximetry is the lowest. We can see that only 10% of primary healthcare facilities have access to a pulse oximeter, which greatly hinders the ability to diagnose and refer for prompt treatment with oxygen. Even within facilities, we see inequities between wards. And I note here, especially when we think of pneumonia, that in pediatric wards in hospitals, only 43% have access to medical oxygen. And this is far lower than we see in surgical wards, which have good coverage, and emergency units. So children with pneumonia are really suffering from this, the lack of access to medical oxygen. So how much would it cost to resolve this problem? I think in the report, we make the case that there's no question about whether investing in oxygen system strengthening represents value for money. It most certainly does. It's more a question of how you should spend it so that your oxygen system is cost effective. In terms of the money that we say is needed, we've estimated that an additional 6.8 billion a year is needed to close that coverage gap. And the largest amount of money is needed in South Asia to close that gap. And it sounds like a lot of money, but it is a highly cost-effective investment. So compared to childhood vaccination programs, so compared to EPI programming, investing in oxygen systems is cost less per DALI averted than investing in your EPI program. And the Global Oxygen Strategic Framework and Investment Case that was published by the Global estimated that for every dollar invested, you'd have a $21 return on your investment. So it's more about figuring out how to raise this money, not whether this would be money well spent. The final section of the report and our findings try to then talk about So how should we spend that money? So if we're requesting this amount of funds to close the gap, how do we effectively close that gap for good? And we had 5 thematic areas for investment. The first is pulse oximetry, then trying to ensure that your oxygen system is resilient, ensuring that there is strong management and governance systems for your national oxygen system, strengthening markets and regulation and standards to support transparency and quality supply chains. And then finally, robust monitoring and evaluation. So making sure that we have the data needed in order to understand where the gaps are and how to plug them. This is what the total picture of oxygen solutions looks like. And we use the term systems very purposely throughout the Commission because it really does require a whole systems approach to have a reliable and robust, resilient oxygen medical oxygen system to ensure access for every patient when they need it. At the top level, there's global strategies that should be put into place, and especially aligning with efforts under the Global Oxygen Alliance, so the goal, ensuring global standards for data and recommendations, and very specifically, we developed and published a national access to medical oxygen scorecard, so the ATMOS scorecard, which has been adopted by WHO for countries to report back to the World Health Assembly. And we would really encourage, if there's any ministry, that scorecard and fill it in and provide the data that's needed to try and provide the global strategic support that countries need to plug those gaps. At the national level, ensuring that there is sufficient financing and an oxygen roadmap or a national oxygen plan in place that is clearly costed and budgeted, that you have strong institutions for training your healthcare workers as well as your biomedical engineers. They are an essential part of the health workforce. And so ensuring that they have sufficient capacity as well as the tools they need to do their jobs well. And then a governance structure that can coordinate all these different parts of the system together. So bridging together medical supply chains with clinical guidelines, with education facilities, with monitoring and evaluation systems requires clear coordination. And so ensuring that that is in place. And finally, at the patient level, so at the facility level, recommending for access to pulse oximetry for all patients. Workers should be able to do an oxygen sample needed, linked to a functional referral system. And when you get to the referral facility, that there would be a reliable oxygen supply. And this really means not pitching one oxygen source against another, but that mixed sources with backups are needed to have a resilient and reliable oxygen supply at the bedside, all supported with biomedical engineering and the age-appropriate equipment for your patients. The report has 52 recommendations that speak to all of these different levels of the system. There's recommendations at the global level, but also at national governments, at professional societies. And so I would really encourage everyone to report, read the recommendations, that you can really take this up as an action to close the gap in medical oxygen for good. So we really want this commission and the recommendations that we put forward to be at the forefront of the future we want to see, ensuring the long-term health and sustainability of people and the planet, clean oxygen systems. So this is where you can find all the information about the commission. Again, thank you so much for letting me share the keynote findings today. It's really a pleasure to carry this work forward. And happy Pneumonia Day. Thank you so much.
So, are you able to see me now? I'm
Yes.
not sure. Well, I thank the organizers for this. My name is Karen Pullman, member of the AIL and a committee on global health and medical oxygen. To understand oxygen inequality, you must know the context of health inequalities in Latin America. Oh, let me see here. Okay. Yes. I'm having some troubles with the audio. I'm not sure if that's okay now. Yes? A conflict of interest. But what I'm saying, understand, we must first look at the context of social inequalities here in Latin America. The World Health Organization defines universal health coverage as the ability of all people to receive the care they need without financial hardship. Yet in Latin America, and the ideal remains far. There is profound inequalities under investments, protection mechanism that leave millions without essential services. Not only also in the relationship between national health investment, and disease burden. Here shows the relation, how much in health per person, total disease and disability 5 years. The burden falls. Sits in a difficult middle ground. Spent more than the yet a burden of disease. In other words, the able to meet its health needs turns a limited inefficiency and inequality. Here we see income inequality expressed by the Gini coefficient. Countries like Peru, Chile, Brazil, and Colombia appeared among the most unequal in the world. Affect more than their income, education, or healthcare. Talk about oxygen, not just discussing medical and this is a risk for families when this map shows the care spend directly from in Latin 30 and 50 health costs compared with 15% of Europe. That means illness often leads to death or poverty. These financial barriers limits access to oxygen. Well, within that context, we can now end up of oxygen therapy. So medical oxygen is one of the saving intervention in global health. Yet you're listening to me because I'm people talking. It's okay. Can someone give me some feedback if you're listening to me?
I can.
Oh, great. Well, we're talking about oxygen therapy, and oxygen is one of the most life-saving intervention in global. Karin already said that the Lancet Global Health Commission on Medical Oxygen 70% global access in countries and plants and systems. Middle in store cause preventable death, turning a basic therapy into a measure of justice and system. Let's look at the epidemic. It shows how powerful the is. Analysis by published in BA Health in 2021 demonstrate that system concentrators, policy, training, and use pneumonia more nearly preventing up to deaths per 1,000 children. The internationally cost-effective 62 per dollar, placing it public health investment worldwide. Well, this is mainly from principles applied with chronic lung disease. And this is the lung. Do an example with Chile. Therapy, it has been part of the national health system for almost the program now 12,500, including more than 10,000, 1,000, mainly patients with COPD and bronchopulmonary dysplasia. Its impact has been significant. Home oxygen has reduced emergency visit by 67% and hospitalization by 50% without increased overall costs. Beyond improving the survival, this approach helps. In other words, what the LAM study demonstrates for children on a global scale, Chile has achieved in practice for adults, turning oxygen access into a long-term sustainability in public. Latin America remains limited in logistical and COVID-19. Many hospitals, plans, maintenance plans, or city depend on costly travelers and 7% pure restricted technology. Altogether complicate in some countries up to 30% cost. Reflect this we saw earlier, technical layered on top economic. So during oxygen prices in some countries, in Latin American countries, such as more than 5 pushing families expanding use of 93 instead percent could reduce 30% clinical safety. Finally, insufficient investment in oxygen has been estimated to cost the 12 in loss of product. So only a economic. So now that we have this, we can explore countries in Latin problem through health system design. So you can see here different countries. This health system faces inequality, sectoral coordination, country defined healthcare varies significantly. For example, in Brazil, right to health protected by law and institutional framework such as Brazil Unified Health EBS reform. These systems promote territorial equity, local governance. In contrast, public and private ensures coverage diseases inequities due to of private and systems. Meanwhile, it's the opposite, high fragmentation among system, such as Salud and the armed forces, resulting in poor coordination, particularly in rural and indigenous regions. These differences of each nation deeply influence not only access to health, but also the continuous equitable oxygen. So to natural practice, yet to ways oxygen use and distributed each model and sustain can be produced three main advantages and implications for air ability. On the hygienic liquid oxygen produced in industrial plants and stored in bulk tanks. It provides the highest purity above 99.5% and the most stable supply, making it ideal for large tertiary hospitals with high oxygen compressed the traditional format in cylinders. It's widely used for patient transport, home therapy, and rural health centers. Its portability electricity, which makes it essential in emergency or low resources settings. Finally, oxygen concentrators or PSA systems generate oxygen on site, offering autonomy and long-term cost effectiveness. They are particularly valuable for remote or crisis situations as they expand access where centralized supply chain cannot be reached. Together, these four When demand spikes, scarcity triggered a black market. Extreme prices increased preventable deaths, and after large donation, many PCA plants ended up to equipment graveyards, installed but non-functional due to regulatory and maintenance failure. This system market failure is not lack of oxygen, it's a failure of the system. So continuing this comparison, we can see how infrastructure and workforce capacity played a defining benefit from reliable power supply and structural maintenance programs, as well as a medical engineering workforce of supporting both and PSA systems. Altogether, structural resilience and financial protection. Peru, in our maintenance systems and of trained engineering specialists. The geography adds another layer of complexity. High altitude region across the Andes significantly reduce PSA efficiency. Combined with regulatory and market issues, the structural weaknesses led to persistent shortage and cost for patients' health. What this ultimately shows challenge, it's structural and political. And to oxygen means strengthening data system human capacity. Some governance protects equity. And I like to highlighting these messages that you can see here, that medical oxygen is both a life-saving therapy and a measure of health equity, that data scarcity we see the stable energy and maintenance planning, not only donations, and achieving universal oxygen access demands investment, governance, and political will, turning equity from aspiration to action. So thank you very much. I hope you didn't have to my presentation. Here are the references. If you need something, please don't hesitate to get in touch with me. Thank you so much.
Hi, everybody. My name is Lewis Bond. I'm a pediatric infectious disease specialist from Utrecht, the Netherlands, also the chairman of the ResVinet Foundation, and it's my pleasure to inform you about advancing RSV prevention, effective vaccines and antibodies for protecting infants globally. RSV infection infects 33 million patients, 3 million hospitalizations, leading to 120,000 deaths, most of them occurring in the first 5 months of life. 99% of children dying from RSV do so in low and middle income countries. If we look at RSV epidemiology, we can see that virtually all children are infected by RSV in the first 2 years of life. About 14% of those require medical attention, at least in the high-income country setting, and 1.8% require hospitalization. And this may not be very different in lower middle-income country settings. And it is important to realize that the majority of children were previously healthy term children until they were infected with RSV. Still, there are some high-risk infants, like children who were born prematurely, as you see at the left side, or children with Down syndrome or congenital heart disease, as you can see at the right side. But what you definitely see here is that if you want to impact on RSV, burden of disease, morbidity, and mortality, we need to protect all infants worldwide. And this is a study to remind you that RSV causes major burden in low and middle income countries. In 10 countries, Gavi-eligible countries around the world, with support of the Bill and Melinda Gates Foundation, we investigated RSV infection among children under 2 at the intensive care unit. And we found that universally, about 30% of all children with respiratory symptoms during the rainy or the winter season were RSV positive when admitted to the intensive care unit, demonstrating that RSV causes major burden universally. And this is probably one of the most powerful research pieces in structural biology that led to the development of vaccines. What you see here in the middle is the pre-fusion conformation of the RSV-F protein, and at the right side, the post-fusion RSV-F conformation. And epitopes that are only visible at the RSV pre-fusion state, which is metastable, only exist for a fraction of a second. But epitopes like site 0 that you see at the tip of the protein in the middle induces neutralizing antibodies, whereas this is much less the case for the post-fusion RSV-F protein, showing that if you would be able to stabilize the RSV pre-fusion RSV-F protein, you would have a perfect vaccine. And this evidence from Jason McClellan and Barney Graham and others, and Jason Kwong, shows that we could make an RSV vaccine. And basically the RSV landscape is as follows. We have monoclonal antibodies that I will show you that are directed against the pre-fusion F protein that I just showed you. We have at the left bottom, we have protein-based vaccines. Basically, these are the pre-fusion F stabilized proteins that are just used as subunit vaccines. Then there's the mRNA-based vaccines that are doing very well in older people. And then there's the live attenuated vaccines as well that have not yet been licensed. So I'm going to show you the examples first of the pre-F subunit vaccine in pregnant women. A lot of studies have been done, but this is the pivotal study, the Matisse study that we did with the lead investigator, Beate Kampmann, showing that RSV vaccination of pregnant women induced antibody titers in the baby that protected them with about 70 to 80% vaccine efficacy throughout the first 150 days of life, exactly the period that you would like these babies to be protected against severe or life-threatening disease. For the antibodies, the story is a little bit different. Manufacturers changed the Fc tail of the antibody in a way that it has a prolonged half-life. There were 3 amino acid changes, also abbreviated to the YTE mutation, that led to an increased affinity for the neonatal Fc receptor that increases the reuptake of these antibodies or recycling of the antibodies, leading to an increased half-life of about 3 months instead of 3 weeks. And to show you that this is really the case, this is a human study in which healthy adults were immunized or injected with these antibodies, and you can actually see that the half-life is indeed about 100 days, making it possible that by a single injection of an antibody, babies are protected against RSV for the first RSV season. So a completely different mechanism of action, but in both cases, both the maternal vaccine and the infant immunization with extended half-life antibodies, children are protected by antibodies. Does it really work? The answer is yes. This is, again, the pivotal study published already more than 3 years ago, where it was shown that there was 75% efficacy, and it already led to regulatory approval in 2022. There is another antibody that is very similar to nirsevimab. It's not directed against site 0 that you saw at the top, but in this case it is directed against site 4, a bit more at the site of the RSV pre-fusion F protein with the same extended half-life. So again, a very special antibody that has similar properties as nirsevimab that I just showed you. And what you can see here is that a similar efficacy is reached altogether of about 80 to even 90% of very severe RSV infection. And again, FDA approval was already obtained in the past year. So now we have two highly active, safe and effective, extended half-life antibodies against RSV infection. Of course, there is a limitation of the antibodies that probably it's a little bit more difficult to get them in lower middle income countries because of because they're biologicals, they're a bit more expensive. But it's good to realize that there are different, very good solutions for this major problem. So let's look at real world data. So does it really work as good as we hoped it would? And the answer can be obtained through different methodology studies. So Rita Rayburn, together as part of a WHO effort, analyzed which studies are required to establish effectiveness of RSV vaccines. And there are basically 3 different types of studies. There is a cohort approach in which you would have like a registry to compare the effects, to analyze the effects of vaccination. Then there is the case control study, which basically compares those who are and those who are not immunized with vaccine. For that type of study, at the bottom you can see that you need a good diagnostic to determine outcome. In case of RSV, that's actually the case, because we have a very good, simple and reliable diagnostic for RSV infection. So that this is an interesting approach. And then there is obviously the pre and post observational study, just measuring burden before and after introduction of vaccines. I recommend you reading this, but if we dive deeper in the case control study design, we get to what we call the test negative design. I'm going to try to explain this by this cartoon that was developed for influenza-like illness, but it's identical for RSV infection. You have a population that is both at risk for disease, and some of these people are vaccinated in red, and some are not vaccinated in black. Then there is a proportion of those who are swabbed at time of symptoms, and then some of these people test positive, that you see here, and some of them test negative, as you see here. And then you can actually determine the proportion of vaccinees or vaccinated people in those who test positive and among those who test negative. And if you compare the relative proportion of vaccinated people among test positive and test negative, then you can calculate vaccine effectiveness, as you can see here at the bottom of this slide. And this is exactly what we're doing currently. So let's have a look at the maternal vaccination program. By now, 1.4 million doses have been administered. Actually, it's already more than 2 million in various countries in the world. And what you can see here is that there is approval in these countries and even more. And does it really work? So in Argentina, a test negative design study was performed exactly as I explained to you just a few seconds ago. And what you can see here is that this is, let's say, the sentinel group, those who were having symptoms, received and did not receive vaccination during pregnancy, those who test positive and those who test negative at time of symptoms. And then the investigators looked into effectiveness of the vaccine. And to make a long story short, this is what came out. 505 children under the age of 6 months were tested for RSV, 286 tested positive, 219 tested negative. And among those who tested positive, 18% had a mother that was vaccinated, whereas among those who test negative, 50% were vaccinated against RSV. So really a very obvious distinction. And that can be used to calculate vaccine effectiveness, as done here in the Burney study. And you can see that very, very nicely, vaccine effectiveness recapitulates what was found as vaccine efficacy in the trials, 70 to 80% effectiveness. We need to realize that this is obtained when mothers are vaccinated at least 2 weeks prior to birth. So when they are vaccinated just before birth, the effectiveness is low. So that is something to keep in mind. And on the other hand, we also need to keep in mind that vaccine effectiveness is much lower when children are born very prematurely. So let's say below 28 weeks, probably the vaccine effectiveness is way too low. But the exact threshold for prematurely born children, we don't know yet, but it's a topic of active investigation. When we look at similar type of studies in the United States, it's these two networks. I will be short. They did a similar analysis. Cases and controls were compared, and vaccine effectiveness was calculated. And again, the vaccine effectiveness is somewhere, as you can see here, around 70 to 80%. So we have a very nice solution to protect babies against RSV during the first RSV season by vaccinating pregnant women. Here again, you can see from the United Kingdom that vaccine effectiveness is 58% in all women, in all children, and 72% in children who were born at least 14 days after maternal vaccination. So emphasizing again that we need to vaccinate women in time, because if we're too close to delivery, vaccine effectiveness drops substantially. So I will come back to that. What will the next steps be? But first, let's look at nirsevimab, the monoclonal antibody. Is it as good as we hoped it would be? So this is a real-world evidence study from Chile, a national birth cohort comparing those who were immunized versus those who were not immunized. So not really test negative design, with seasonal catch-up versus seasonal immunization versus the catch-up, about 50-50. And the effectiveness was 76% against RSV hospitalization, RSV intensive care unit admission, 85%, and all-cause respiratory infection hospitalization, 67%. So this is even a little bit better than the maternal vaccine program. And very interestingly, with a historic control, there were no deaths during the season by RSV infection, whereas there were 13 in the previous season. So giving the impression that immunizing against RSV may prevent RSV-related deaths, which is something that I think we all find very important. So by now, this is going very rapidly. A lot of real-world evidence studies by nirsevimab have been used in the high-income country setting. Nirsevimab is used a bit more often than maternal vaccination. And you can see here that the effectiveness is even higher than 80% for various outcomes. If we do a meta-analysis showing that we have a safe and effective intervention, again, to prevent life-threatening infection by RSV. So what I've shown you is that there is major burden. Let's say the 30% rule, that 30% of all life-threatening respiratory disease in the winter season in children under 2 is caused by RSV infection. That there is a very rich pipeline with antibodies and maternal vaccination as lead candidates that are equally very safe and effective to prevent severe disease, and that we have seen various test negative design studies to demonstrate effectiveness by using real-world data, both for the maternal vaccine in Argentina and the monoclonal antibodies in Chile, showing really beautiful data. So, of course, in the back of your mind, you have the question, how will we reach those who need it most? So we have good products and they work, but how will we get them to the low and middle income countries? And for that purpose, we need the Global Alliance for Vaccines and Immunizations, Gavi, for obvious reasons. And a large consortium together appealed to Gavi when they were making a decision last summer, please recommend RSV immunization, vaccination specifically for RSV for the Gavi eligible countries. And it is my pleasure to inform you that Gavi has made a positive decision based on all the evidence that we have seen so far to recommend RSV and prevention by maternal vaccination as part of the envelope that Gavi eligible countries receive for vaccination in their respective countries. So, of course, I can't leave you without showing, please take your cell phones and take a snapshot of this QR code, because RSV is still a fairly unknown disease. And what we really want is awareness of RSV in all places around the world. And the chatbot is really working well by WhatsApp or online. And if you use this QR code in any language that you know, you will get all the information you need to know what you need to know about RSV infection. So before I leave you, I want to acknowledge my colleagues at Yale, Dan Weinberger and Jin Pizza, my colleagues at the ResVinet Foundation, in particular, Heather Zah, who has made a wonderful contribution to the field, as all the others. And at the right, you see my research group. While I'm talking to you, they are doing the hard work. Thank you very much.
Hello, good afternoon, good morning, good evening. My name is Dr. Matthias Hassa-Gobsowicz. I'm a technical officer in the immunization department at the World Health Organization. And today I would like to thank the organizers for inviting me to speak at this conference on how we can use vaccines to prevent antimicrobial resistance. I'll start with this graph, which shows the overall burden of antimicrobial resistance that was estimated by the Global Burden of Disease study in 2021. And what they have found is that globally and annually, AMR is associated with 4.7 million deaths associated with AMR annually in 2021. And if you see the results on the right-hand side and the graph with all the pathogens and how they contribute to these infections, you can see that the three leading pathogens together, they contribute to 2.3 million deaths associated with AMR. And the number one pathogen associated with resistance is Streptococcus pneumonia, followed by Staph aureus, and then followed by E. coli. So this is a really large burden to use to reduce. One of them are vaccines. How can we use to reduce and what are the mechanisms for? Firstly, vaccines can prevent both drug susceptible but also resistance. They also can prevent you individually from getting sick with a drug-resistant pathogen, And also, if sufficient number of people in communities are vaccinated, they can also protect those who are not vaccinated for herd immunity. This is particularly the case for pneumococcal vaccines. Through reducing the number of infections, they also reduce the need for antibiotics that one takes to treat these infections. Therefore, they reduce that need for antibiotic treatments. And by reducing infections, by reducing antibiotics, they also decrease the evolution of new resistant genes and also transmission of pathogens between people and between communities. So if you think of vaccines in AMR, you may think, okay, at what point do I actually consider the role of vaccines in reducing AMR? And what you see in this slide on the very top is a continuum of vaccine development, starting from very early development all the way to having a policy decision, implementation in countries and sustainable use of vaccines. And at the bottom, a corresponding vaccine impact on AMR with different stages of starting on the very left, which is early development. And here, vaccines such as for gonorrhea or for Klebsiella, where a decision was being made of whether to invest in these vaccines, the AMR component is really heavily featured in that analysis. Later, as you progress through clinical development and you evaluate the impact of vaccines, either on the prevalence of AMR, in the case for Streptococcus pneumonia, which was often measured in the context of clinical trials, or for RSV, where the impact on antibiotic use was evaluated. And then later, as you progress through regulatory approval, policy decision, where, for example, for Salmonella typhi, and resistant outbreaks, particularly in the big decision driver, introduction of the immunization program. Gavi, an organization that from countries investment strategy every 5 years, criterion that would the impact of vaccines and how should that be with regards to which are supporting. And then later, using vaccines in countries and also how you evaluate the impact of vaccines once a vaccine is being introduced. So we know that vaccines could contribute for various mechanisms across different stages. How can we strategically integrate them into plans and strategies to reduce AMR? And one example is how they are reflected in national action plans against AMR. And these are country strategies that countries need to develop in order to explain how they plan to reduce antimicrobial resistance in their countries. And there was an analysis done which looked at 77 national action plans on AMR and how many of them integrate vaccines as interventions to reduce AMR. What they found is that actually a large proportion did, almost 87% of national action plans did mention vaccines, but only less than a half, 43%, have actually developed indicators that would allow to capture the role of vaccines against AMR. And 10% of them didn't at all, which is really them were high-income countries, which should be driving the agenda of inclusion and vaccines and AMR. What this means that there is some understanding of the role that vaccines have in reducing AMR, but it doesn't necessarily translate into action and integration with other AMR prevention interventions. Why that could be? We believe that one of the major gaps why this may be the case is because there is lack of understanding as to what extent can vaccines reduce AMR. And this is what we at WHO have tried to address. So last year, we have published a large analysis in which we had estimated what is the impact of vaccines in reducing antimicrobial resistance and use. We've modeled the impact of vaccines against 24 different pathogens and found that annually vaccines have the potential to avert up to 515,000 deaths, 28 million deaths, 30 billion hospital costs, 20 billion activity losses, all associated with antimicrobial resistance, and that this is in addition to vaccines having a potential to reduce antibiotic use by 2.5 billion doses annually. And I invite you to read the report that we had published last year. And over the next couple of slides, I will go to details of some of these results. Firstly, when you look at the vaccine averted health burden and the number of deaths that vaccine can avert, in total, we found that it's 515,000 deaths that vaccine could avert, associated with antimicrobial resistance, and the largest proportion of these deaths could be averted in the WHO African region, over 30%. If you look at the graph on the right-hand side, each bar is a corresponding vaccine, and you can see the vaccine that makes the most impact is a tuberculosis vaccine that would avert around 120,000 deaths associated with AMR. Yeah, XPEC, and then streptococcus and BMG Global Health, which I invite you. The second lens to look at vaccine impact is to look at how much antibiotic use they could avert. And we've estimated that they 1.5 billion defined daily doses of antibiotics, which is around 20% of the total burden that we had estimated. And the largest proportion of that burden, averted burden, is in the Southeast Asia region of WHO. Different vaccines, how they contribute to that averted burden. The number one vaccine, which is 1.8 billion antibiotic doses averted, is from tuberculosis. And this is because you take antibiotics for a very long time and you take many antibiotics at a time. Followed by XPEC, Staph aureus, Group A strep, influenza, and then streptococcus pneumonia vaccines. And also we look at the cost treating drug-resistant infection. So we wanted to understand the incremental cost of treating drug-resistant infection versus having infection from a hospital cost perspective. And we found that collectively, these different vaccines, they could avert up to 30 billion in hospital cost. And the largest proportion of these costs, averted costs, would be in the American region of the WHO. And this is because with countries like the US and Canada, you have very, very high costs of hospitalization, which are the main driver of that figure. And on the right-hand side, you can see vaccines that are the main contributors to that cost, Staph aureus and XPEC, which are pathogens and infections that you get often in hospitals. They require long hospitalizations. And this is why there's such a high cost associated with them. And again, this study has been published in BMG Global Health 2, which I invite you to read and have a look at. In the report, if you go to the WHO report, you also see a number of additional resources. So we have dashboards that we have developed for each of the pathogens. Here you have Mycobacterium tuberculosis, and then at the top you have a description of a vaccine. And then in 3 tables below, you have the impact of such a vaccine on AMR health burden, antibiotic use, but also the economic burden. We've also developed a website, a dashboard, where you can look at one vaccine at a time and see what impact such a vaccine has on AMR, but also to compare different vaccines and see for a given criterion, let's say health burden associated with AMR, which vaccine would have the most impact. If you Google WHO vaccines AMR, you'll be able to easily find this dashboard. I've described some modeling analysis that WHO has done, and there are a number of other modeling analyses, so I'm not showing you all of the evidence that exists. But here, I'm switching gears a little bit, and I'm now showing you the results of observational studies, studies from clinical trials, results from clinical trials that show the impact of vaccines on AMR. And this is a very interesting graph because I think here the impact is very visible. This is the impact of pneumococcal vaccines on the prevalence of non-susceptible invasive pneumococcal disease in USA. This is in children. And what has happened is that after the introduction of pneumococcal conjugate vaccine 13, you can see a drop in antibiotic-resistant cases between 2009 and 2013 for various antibiotics, between 60% of macrolides to a little bit over 80% for penicillins. Over time, the prevalence of AMR has changed because new serotypes are causing disease. They're being treated with antibiotics, and then that's where resistance is growing. But nevertheless, you can see a really large impact of vaccines. There was a review in one of the articles which looked at studies, pediatric isolates that looked at the impact of pneumococcal conjugate vaccines over 10 years after vaccine introduction. And they found 11.5 decrease in isolates that are non-susceptible to penicillin, and up to 10% decrease of isolates non-susceptible to other antibiotics, recognizing that this is in various settings, in various contexts, and across all the different populations. There was also a study that was being conducted that collected data from demographic health surveys and multiple indicators cluster surveys, which looked at antibiotic use of children under 5 in low and middle income countries and evaluated what is the impact of vaccines at the current coverage. So at the time of doing this study, I think this was around 2020, and the coverage of pneumococcal vaccines was around 50%. On the coverage of rotavirus vaccines was probably a little bit higher than that. And what they estimated is at that time, pneumococcal conjugate vaccine has already prevented almost 24 million antibiotic-treated episodes annually, and rotavirus vaccine already prevented around 14 million antibiotic-treated episodes annually. But if we were to increase the coverage of these vaccines to what WHO recommends is 90% coverage, pneumococcal vaccines could additionally avert 22 million antibiotic-treated episodes, and rotavirus vaccines could additionally avert a little bit over 18 million antibiotic-treated episodes annually. So what this shows is that we already can do a lot with what we have, but also with existing tools. If we increase the level of use with existing tools that we already have, we can really have very, very big impact. And this was published in Nature. I invite you to have a look at that. You have a link just at the bottom. Now, so if you think of these different impacts, you could also say, okay, what vaccines then are being developed in order to tackle resistance and target some of these pathogens that I have just mentioned. And in 2021, we have bacterial pipeline, and we found that there were 61 vaccines in active clinical development. And then the highest number of these vaccines was unsurprisingly for Streptococcus pneumonia, 16 vaccines, followed by 13 vaccines for TB and 6 vaccines for Shigella and ETEC. I think very worryingly, for pathogens that are critically important for AMR, like Pseudomonas aeruginosa, Acinetobacter baumannii, there were no vaccines in development. For some of them, there is a little bit more work in clinical development right now, but nevertheless, it shows that for the next 10 years, we're not going to have these pathogens. The reason for that perhaps not appropriate for the populations that we would like to target these vaccines, easy to get to. Our vaccines then integrated our strategy, and I will give you a couple of examples of some work that's happening in WHO. The very left, Global Action Plan on Resistance, which was published in 2015. This is a global strategy as to how we should be reducing antimicrobial resistance, what strategies and actions countries should be taking in order to develop national action plans on AMR. And importantly, there is currently work taking place which is revising this global action plan on AMR, and this is particularly to align with the UN high-level meeting that took place last year, where there were goals signed. There was a global declaration that was being signed by all of the member states that makes using AMR goals. We need global strategies. The second document is a people-centered approach to address antimicrobial resistance in human health. And this is a core package of interventions that we recommend to countries and we support countries with to integrate into the national action plans. And I'm happy to say that vaccines very prominently feature in that package of interventions. And then lastly, another example is a global research agenda for antimicrobial resistance where in a structured approach, we've identified AMR in a couple of examples. One, understand value of vaccines and how to best of implementation studies, which should be and their anticipated impact. To have something that is really specific, because we felt that across all these different vaccines are not prominently reflected when we talk about and we published something that we call framework, which calls for leveraging vaccines to reduce antibiotic use and prevent antimicrobial resistance. And this is a list of actions for pharmaceutical industry, academics, researchers, funders, etc., as to what they would need to do in order to better reflect the use of vaccines in reducing AMR. And these actions are centered around three strategic pillars. The first one is how we can appropriately expand the use of licensed vaccines to maximize the impact on AMR. And it's the example that you saw in the previous couple of slides. We already have good vaccines for pneumococcus. If we were able to use them really well and reach global coverage levels, the impact could be much, much, much greater. Develop new vaccines that contribute to prevention and control of AMR, particularly those vaccines that are in late stage development, like Mycobacterium tuberculosis vaccine, new vaccines against ETEC, etc. Also to expand of vaccine impact on AMR. There is still limited data coming from low-income countries, which limits our potential to model and understand vaccines in these settings, where the burden is often the greatest and the need is the highest. So that just brings me to a couple of conclusions. We've estimated that vaccines have the potential to annually avert up to 515,000 deaths, around 30 billion in hospital costs associated with AMR, and around 2.5 billion of antibiotic doses. Importantly, the impact of vaccines it needs stakeholders both AMR environment, but also environment, regional and national AMR and immunization and implementation strategy and different frameworks. They should ensure that they include vaccines as interventions to reduce antimicrobial resistance. Importantly, the introduction of existing vaccines like for pneumococcus, for typhoid, it needs to be accelerated and the coverage increase to what WHO recommends should be the appropriate coverage. The existing pediatric vaccines should reach the targets of the Immunization Agenda 2030, which is the strategy for immunization for this decade. And also we should consider the use of vaccines in older age group, where particularly the issue of AMR is greatest. We also need to think how we can prepare for the introduction of newly developed vaccines. How can we act in a systematic way and embed that into existing decision frameworks? And this could be either we're making a policy decision at the global level or at the country level, and how can we already consider that data on AMR in making that policy decision as to whether to introduce and how to use that particular vaccine. And also think of some of these pathogens and vaccines where vaccines are very early in development. Be the case because there are a number of technical issues with developing such a vaccine. What do we do in order to support that? And one of these ways is to develop perhaps research roadmap, which is now what we're doing for Klebsiella pneumonia, where we're trying to map different vaccines and what research would need to be conducted to overcome these challenges so that we can get to a point where we understand how far we are from developing a vaccine against Klebsiella pneumonia. To some other, like developing preferred product characteristics, which would describe, and then later developed, help us perhaps include some of these AMR-related endpoints in clinical trials, so we can already in clinical trials gather data on the impact of vaccines on antimicrobial resistance. And really appreciate and huge thanks to the organizers for including W.
Connection.
Hi, can everyone hear me? Hello, everybody. I hope you can hear me okay. My name is Antonia Ho. I am a professor of infectious disease. I'm based at the MRC University of Glasgow Centre for Virus Research in Scotland, and I'd like to thank the organisers for inviting me to speak about influenza A today, and I've really enjoyed all the talks so far. So just briefly, my declarations are here in terms of my previous employment and also research funding and support. Just very briefly, one slide, because this will become important for my talk later on. So just for some of you, this might be very familiar, but just for those who are less familiar, I just want to introduce the influenza A virus. It has kind of two surface proteins, hemagglutinin and neuraminidase. There are 18 types of H and 11 types of N. And the role of the hemagglutinin is to bind to the cells of the infected person, whereas neuraminidase is to kind of release virus from the cell surface. And they are therefore kind of numbered depending on which H and which N. So you've obviously heard of kind of H1N1, H3N2, for example. And the key circulating human influenza viruses until recently has been AH1N1, AH3N2, and two B lineages, Victoria and Yamagata. I will go on to talk to that. Kind of a key part of understanding the threat really is surveillance, and the Global Influenza Surveillance Network and response system through the WHO has been in place since 1952. And now we have kind of in excess of 140 national influenza centers, and there are kind of 5 WHO collaborating centers that are based in the US, China, UK, Australia, and Tokyo. And their role is really to kind of monitor human flu burden, monitor antigenic drift. So that's kind of one of the key features, is that there are influenza A is in particular very prone to mutation. So you may have heard of antigenic drift and shift, where there is a major change in the antigenic presentation of a virus, and as well as monitoring antiviral resistance, and also kind of collating viral isolates to choose for select the viruses that need to go into a vaccine every summer. This occurs twice a year. So they select vaccine strains for the Northern Hemisphere in February of each year, and in September for the Southern Hemisphere of each year. And also monitor for kind of zoonotic and influenzas of pandemic potential. So this is kind of some screenshots of flu activity contributed by data from various national influenza centers from around the world. Surveillance has changed a lot since the COVID-19 pandemic, as the WHO now realizes there are, in addition to influenza, there are now other viruses that we've just heard about, RSV later on, and of course our lives have been dominated by SARS-CoV-2 in recent years. And rather than having separate surveillance systems for all these different viruses, it makes sense to kind of integrate these surveillances based on different respiratory viruses. And there were interim guidelines that came out in 2021, and more recently that came out last year to kind of, for different countries to deploy kind of year-round sentinel integrated surveillance, and ideally combining not just laboratory data, but also integrate with clinical data if it's possible, to really understand clinical severity, and also combining surveillance data, sequencing data also. So just to give you an idea of what an integrated surveillance, syndromic surveillance sounds like. So rather than looking at pathogen specific, I know that like a high proportion of you are clinicians. We know that testing is is very variable in different healthcare facilities. For example, some are tested for one virus, others are tested for other, and testing really varies depending on clinical severity also. So since 2021, we've developed and implemented an enhanced syndromic surveillance. So I have a team at the emergency department that recruits patients that fulfill a severe acute respiratory illness criteria. They then collect minimal clinical information in an electronic CRF. Patient has a point of care PCR test for influenza and SARS-CoV-2. This is then put in place in the eCRF and linked to routinely collected National Health Service data, which is really rich in information, contains kind of comorbidity, socioeconomic information, discharge, diagnosis, for example. And we also use this platform to look at additional respiratory diagnostics, so a full panel of respiratory viruses, use it to evaluate novel diagnostic tools, as well as using it as a platform to recruit patients into randomized control trial for various respiratory viruses. And it provides Public Health Scotland, our national public health body, weekly data on proportion flu and COVID PCR positive by age group. So just to kind of give you a snapshot, so this is the kind of weekly positives of flu and COVID that gets sent on a weekly basis. Previous to that, it would take months for this kind of data to go to our public health agencies. And what has the COVID-19 pandemic, what has it done to influenza circulation? Like many countries, and I've just kind of captured one particular study, but I think many studies around the world has shown substantial reduction in community influenza circulation. This is from a kind of community flu surveillance study in Seattle. And another very curious thing that happened was that, as you recall earlier, we normally have 4 different types of influenza viruses that tend to circulate. But one of them apparently became extinct really since 2020. So the B Yamagata lineage was the last genome that was uploaded was back in March 2020. And there have been a few detected since, but mostly associated either with misclassification or they were kind of vaccine strain related with live attenuated vaccine. And a lot of the thought of this kind of marked reduction in community flu circulation, as well as other respiratory viruses, is really largely due to the kind of global implementation of non-pharmacological intervention that was designed really to mitigate SARS-CoV-2 transmission. So because of these findings, since September 2023, the WHO has recommended the exclusion of the B Yamagata strain in influenza vaccines. So majority of influenza vaccines prior to that were quadrivalent, so included 4 strains, but increasingly, because it takes time for manufacturers to take it out, because they then have to go through various testing and effectiveness testing. But largely, the majority of influenza vaccines that are now being prescribed are trivalent now. Next generation sequencing has also become increasingly important, as evident by the recent SARS-CoV-2 pandemic. And really, this really allows us to monitor. So you may have heard of GISAID, which is the kind of repository of where the kind of genomes was originally set up for influenza. But since then, there has been, I think, over 16 million SARS-CoV-2 genomes that have been uploaded. And I'm going to go into this a little bit later, but there has been really an overtake of a particular variant, the K variant, particularly noticed in the last few weeks in the UK. And, combining genomic information around the world, we really are able to kind of see contribution of different viruses, and also how the virus strains have differed to vaccine strains, which you can see are here as like tiny crosses. So actually, the the vaccine strains for the Northern Hemisphere now are here and here for the egg vaccine, and also for the cell culture-based vaccine, whereas these two are the recommended strains for the Southern Hemisphere that was recommended back in September. So we're already, so this cluster here is the current kind of dominating strain that we seem to be veering away, and I'll talk a little bit about that a little bit more. So what I did show you earlier is, you know, the contribution of sequences from around the world, but you know, although I think sequencing capacity really increased substantially during the SARS-CoV-2 pandemic, you know, our ability to monitor different viruses still really differ substantially across region. So one of my PhD students downloaded all the genomes from GenBank, which is where all the, you know, publicly available sequences are available, for 12 non-SARS-CoV-2 respiratory virus groups over a 25-year period. And as you can see here, flu A and flu B are the best represented across all the regions, but really they are more dominant in particular regions, and there are substantially fewer genomes submitted per million population compared to other regions. And for other viruses, it is much patchier. So we really need to increase sequencing capacity in other regions, and particularly in the African region, and to some extent in parts of Asia also. Another thing that has really taken off during the pandemic is really wastewater surveillance. It's really another kind of adds to really kind of our armamentarium of tools to kind of monitor what's going on. Because, you know, testing really involves individuals getting tested, and certainly for SARS-CoV-2, you know, during the pandemic, there was a lot of community testing, but largely what we know of what viruses circulate largely depend on patients or individuals that are ill presenting to healthcare facilities to be tested. And wastewater surveillance may represent really a kind of cost-effective way to monitor what is going on in the community. But there has to be a kind of systematic approach to kind of selecting your sampling locations in terms of, so you might want to ensure that all the geographical locations across a country or a region is represented, but you may also want to focus on particular regions, for example, hospitals or particular animal populations you might need to monitor, including cattle due to kind of recent outbreaks, or kind of bird migratory routes, for example. But it provides a tool. You could look at multiple viruses at the same time, but it may kind of provide an early warning system because it kind of shows you what is occurring in the community, which usually happens before patients start presenting to hospitals. So here are some kind of examples of influenza wastewater surveillance. This one on the left here represents work from looking at influenza genome copies compared to flu incidents in 4 particular regions. And as you can see, it maps pretty well. So the flu A virus RNA gene copy number in the wastewater appears to correlate with the number of confirmed disease cases in the Finnish National Infectious Disease Register. And another surveillance that has happened across 38 wastewater plants in 10 districts in Shenzhen, and they basically found that they can combine all the data from the wastewater, really define a baseline, and they can really identify a kind of 2 to 4 week early warning before infection cases start appearing. So kind of allows you to think about kind of pharmacological interventions when you might want to deploy vaccine, but also kind of inform your healthcare utilization as well. As I mentioned earlier from the next generation sequencing, we've seen this kind of uptake And the genomic sequencing really has allowed us to understand, in the UK, we are seeing a very early influenza season. So this is UK Health Security Agency data looking at the last 3 or 4 years of influenza test positivity. And as you can see this year, it seems to have appeared 5 weeks early. The cases currently are being driven by kind of older children, 5 to 14 years, as well as 15 to 44-year-olds. But slowly, as I said to you, cases tend to appear in the community before hospitals. We are now kind of seeing a small uptake in hospital admissions, and that's primarily in 85 and over and 65 to 74. And it appears that most of this, 98% of the cases that have occurred since September have been H3N2, and 84% of those subtyped is an H3N2. And early flu seasons have also been reported in other Northern Hemisphere settings, in Japan, as well as in other cases in Europe. And genomic sequencing suggests, as you saw earlier, that there are a number of multiple mutations that seems to have occurred over the summer. So appears that the AH3N2 that's currently circulating may be genetically be quite different from the vaccine strain and also from the general population's pre-existing immunity. So this is kind of hot off the press. This is a preprint released by the UK Health Security Agency yesterday, essentially kind of showing in antigenic characterization. So they looked at how the antigenic response using kind of hemagglutination assays, and showing that really there's been multifold increase in the response to kind of vaccine strains. But however, it looks like it has really deviated from kind of previous vaccine strains or existing vaccine strains. The good news is that early kind of vaccine, if there appears to be reasonable vaccine effectiveness to emergency department attendance as well as hospital admissions. So this is kind of stratified. So we're only looking at AH3N2 because there's hardly been any H1 circulating. Vaccine effectiveness is always much better in younger adults compared to older adults for H3. So the vaccine effectiveness appears to be over 70% in kind of younger adults, around kind of 60% in older adults, and about 30 to 40% in the over 65s. So although genetically appears to be quite different, there appears to be some cross protection, and vaccine effectiveness is not that different in early seasons from previous years, but that requires ongoing monitoring. One thing that's also really important is thinking about bacterial co-infections and influenza infections, because these data really inform whether empiric antibiotics should be prescribed. And we've just heard a talk about antimicrobial resistance. So there has been to date a couple of systematic reviews that have characterized bacterial co-infection in influenza, the first of which included studies from between 1982 and 2014. All but one study really focused on the 2009 pandemic H1N1, and a really high proportion focused on intensive care unit patients, which of course often have a higher prevalence of hospital-acquired infection. The second one is more recent, covering a period between 2010 and 2021. Sorry, this is a typo. And they found, this study looked at whether co-infections were associated with higher admission to ICU, which it does, but I have an issue with this mainly because patients who are in intensive care are probably more likely to have bacterial culture sent anyhow. In any case, essentially the kind of pool prevalence from the first systematic review, it's really small here, but it's 23%. And for the second one, is 20%, with Streptococcus pneumoniae and Staph aureus being the two key pathogens. And this is really important because in SARS-CoV-2 work that we have done in our group have demonstrated that community-acquired bacterial co-infection is really very uncommon. And actually the kind of causative pathogen, co-infecting pathogen are usually Staph aureus and E. coli, whereas Streptococcus pneumoniae are less prevalent. So this kind of tells you that when a patient presents in the front at the front door with an acute respiratory illness during a winter season, unless you're very conscious or aware of what the epidemiology of influenza and SARS-CoV-2 is, then a point of care test at the front door will really help you try to determine the likelihood of bacterial co-infection, and you're probably much more likely to prescribe antibiotics if someone has influenza infection, of course, with potentially other markers like raised inflammatory markers or consolidation on chest X-ray, but these are all very prevalent in SARS-CoV-2 infection. So sometimes this doesn't help, but knowing what the underlying respiratory virus is. So we are currently updating this systematic review. So this is just work in progress by another student of mine, Harrison. We have included all the studies that were included in the two previous ones and included 36 additional studies that cover 30 countries. This kind of shows you the distribution of countries, but nearly half of it comes from either China, Spain, or United States. So there is very poor representation of large regions of the world. And again, 2/3 of the studies were focused on a pandemic H1N1 period. This, again, you don't need to be able to see, but this kind of outlines the time span of the studies. And this is when the kind of pandemic H1N1 was recommended as the vaccine strain over this time period, back to seasonal, and this is during the kind of pandemic, COVID pandemic period, and only kind of 40% had reported on antimicrobial use. And pool prevalence so far, and again, this is just early work, is that the pool prevalence is around 18%. We haven't stratified this by intensive care visit and slightly lower in children, but antimicrobial prescription is very, very high. In adults, strep pneumoniae is the most prevalent co-infecting pathogen, followed by Staph aureus, whereas it's the other way around in children. So again, something to bear in mind, and we hope to be able to share, to submit the manuscript quite soon. Moving on to kind of diagnostics, I'm not going to really talk about kind of laboratory-based PCR because that's kind of been around for a long time and fairly standard, but I think increasingly kind of point-of-care tests are being deployed. The kind of first generation of point-of-care tests were kind of antigen-based immunoassays, which had very good specificity, but very poor sensitivity. And then we then had kind of nucleic acid amplification tests. So these molecular tests have far better sensitivity, and they had been approved by FDA since about 2015 and kind of probably fairly routinely deployed in the late 2010s. But since the COVID-19 pandemic, initially there were kind of influenza RSV multiplexed NAT tests, but increasingly, a lot of kind of clinical areas have combination respiratory viral panels, like including kind of flu RSV plus and COVID-19 as well. These are some of the platforms that are available, and turnaround time is kind of going down. That a lot of them are less than an hour. These are some of the kind of approved ones that are in routine care, including kind of CEPHID, QPOC, as well as the Biomerior, the Cobas, sorry, this is a Roche platform, Cobas Liat platform as well. So you think these might really improve patient care, but do they? A systematic review in 2023, led by Tristan Clark, looked at 27 studies in over 17,000 patient encounters And most of the studies used this kind of biofire respiratory pathogen panel that looked at a huge number of pathogens, with a turnaround time of 45 minutes. And they basically showed a faster time to result of over 24 hours, reduced length of stay by almost a day, more appropriate neuraminidase inhibitor use in flu-positive patients, and also more appropriate infection prevention control in flu-positive patients as well. But it didn't have any impact on antibiotic use or duration of antibiotics, and it probably wasn't powered to look at mortality as well. And why would that be? And my postulation is that because the turnaround time is still too high, really, to kind of impact on antibiotic prescription. Lateral flows, continuing on like diagnostics, like lateral flow tests became a really big part of diagnosis in the community in particular. And really, you know, lateral flow tests have been around for a really long time, particularly for things like malaria and HIV tests. But really during the pandemic, it's really kind of accelerated the development of point of care tests. And there are now kind of increasing new technology like enzymatic nanoparticles, as well as kind of CRISPR technology that really improves sensitivity and really also driving kind of multiplex rapid antigen tests as well. And just to show you, there's been a study that have evaluated the performance of a number of kind of multiplex lateral flow tests that include kind of influenza A, and the sensitivities are largely pretty decent, over kind of 80%, in particular for samples with low CT value of less than 25 and 25 to 29. So perhaps more important and maybe highlighting kind of patients who may be highly infectious, sensitivity is pretty good, except for those with a low viral load. So moving on to treatment options. So just to kind of show you the different types of influenza antivirals, in the interest of time, I'm not going to go into them individually, but the ones that are most well known are the neuraminidase inhibitors. As you recall, neuraminidase is important for kind of viral release. So inhibiting it basically prevents virions from being released. And previously, the ion channel M2 inhibitors were also used, but largely there has been widespread resistance to influenza A, so these are no longer used as well. In terms of the supporting evidence for influenza antivirals, there is really scant data from randomized control trials, really. A recently published systematic review in Lancet in 2024 showed that kind of oseltamivir and peramivir reduced hospitalization by 1.63 and 1.73 days, respectively. And a large meta-analysis with nearly 29,000 patients showed that neuraminidase inhibitors was associated with reduced mortality, and that effect was greatest if it was given within 2 days of symptom onset. But that is often challenging because patients don't often get tested, which is where I think kind of point of care tests will come in. And there are cohort studies also, but really there's very limited randomized control trial data on neuraminidase inhibitors. Some other observational studies showing kind of shorter length of stay, and there is ongoing randomized control trials using baloxavir in severe influenza, but there is evidence suggesting that there is kind of a higher prevalence of development of resistance when using as kind of sole therapy in mild influenza. So there's kind of concern about using them on their own and whether kind of combined therapy is useful. However, a number of randomized control trials that have looked at combination therapy have basically found no clinical benefit compared to single agent therapy. So the WHO updated their clinical practice guidelines last year, and this is kind of currently the summary of the kind of treatments that they recommend. And importantly, kind of none of the adjunctive therapies currently have any evidence for them at present, but there are kind of ongoing trials looking at things like steroid and inflammatory effects of macrolides as well. This is a kind of summary of the kind of therapeutic landscape, and it's quite healthy at the moment, but of course things that often take time and lots of resources required to take these through the different phases of trials. So we need to watch this space and see where this goes. So I'm almost at the end. Kind of thinking about influenza vaccines, which are kind of really the most important tool that we have to protect ourselves against influenza. There are many types of influenza vaccines. These are all the ones that are available in the UK, and some are targeted at different groups. For example, live attenuated vaccine nasal spray is given really only to children. And for older adults, we tend to give either the adjuvanted or the high dose trivalent inactivated vaccine, because they tend to generate a poorer immune response and have lower vaccine effectiveness. And just kind of really to show you, I thought this was quite a nice illustration of data from the US Vaccine Effectiveness Network, really summarizing kind of vaccine effectiveness against the three key kind of influenza types. And as I say, vaccine effectiveness is always better in children, always better for H1N1 as well as B, and always much lower in H3N2, particularly in lower adults as well. So we really do need kind of newer types of influenza vaccine, because both egg-based and cell culture vaccines require kind of 6-month manufacturing time frame, which is why kind of the recommendations for vaccines have to come so much earlier than the time when they need to be given. But there are, again, a really healthy pipeline of new novel vaccines. So recombinant vaccines have much shorter manufacturing time, around 2 months. And then as well as mRNA vaccines, there are a number of mRNA vaccine candidates that are now in phase 3 trial. So we need to watch the space, although a number of them are quadrivalent vaccines before B Yamagata was taken out. So we're not sure where this is going to go. And I kind of wanted also, lastly, to kind of finish on highly pathogenic avian influenza, because that's been very, very topical, and I've been asked a lot about this. You know, avian influenza was first emerged from H5N1 first emerged from southern China in 1996 and caused a kind of large poultry outbreak in Hong Kong in 97, causing 20 infections and 7 deaths. And really, that outbreak was controlled, but unfortunately the virus continued to spread. It wasn't eradicated in birds and resurfaced and spread widely throughout Asia and later in Africa, Europe, and the Middle East, causing kind of large poultry outbreaks and sporadic human infections. And since 2003, there's been in excess of 900 sporadic human infections in 24 countries. As far as we're aware, that's been reported to the WHO. And most avian influenza viruses predominantly infect birds, but there has been increased detection of H5N1 in non-avian species globally, including kind of wild and domestic kind of terrestrial and marine mammals, and more recently in both goat and dairy cattle in the United States. How does it impact on humans? Essentially, it causes a wide spectrum of clinical presentation. These are kind of some of the reported signs and symptoms and complications, and essentially it's pretty clinically indistinguishable from seasonal flu or SARS-CoV-2. And you may have heard of this kind of 2.3.4.4b clade, which has been remarkably successful in spreading and global spread since it arrived in Europe kind of mid-2020 and then into North America. And then into South America mid-2022. And really, with the exception of a couple of cases in Cambodia in January 2022, all cases that have been reported since then have been this 2.3.4 4.4b clade. This clade has been circulating, as I say, in a lot of different types of animals, but also in dairy cattle, and we've really identified specific mutations relating to the viral RNA polymerase that's been associated with the cattle outbreak, which basically means that it's been able to adapt to mammals very well, which is obviously a concern because it's one step closer. But as far as we're aware, there are no human-to-human transmission of this virus. So I will end there in terms of preparing for the future. Hopefully, from what I've said, we really need to adopt a One Health approach and integrating surveillance. And that doesn't just mean combining kind of human and animal efforts, but also combining laboratory, clinical, sequencing data, including wastewater, to allow us to better predict circulating strains. Really kind of invest in affordable kind of point of care diagnosis, enable a kind of earlier diagnosis, also allow accessibility, particularly for low and middle income country where flu diagnostics are kind of out of reach, but also importantly improve antimicrobial stewardship and reduce antimicrobial resistance. And kind of the future is quite bright for novel influenza vaccines and antivirals, but we need to keep looking for them. And so thank you very much for listening.
Hold on a minute.
Good morning, good afternoon, everybody. Can you hear me okay? I can't actually hear anybody.
Yeah, you're very clear.
Oh, okay, Antonia, thanks. I can't hear. Okay, good. Maybe I'll just get started then. I can't hear at all. Okay, so I'm going to be talking about simplified and fractional dosing of pneumococcal vaccines, and thank you very much to the organisers for asking me to present. So the pneumococcal conjugate vaccine has been around for more than 25 years, but as of the latest coverage figures, only 67% of the world's children are getting vaccinated. So this is despite, as I mentioned, being available for 25 years. And recently, a review by us found a 15% reduction in pneumonia admissions and about a 30% reduction in pneumonia deaths. And it's been estimated that since the vaccine was introduced, about 1.6 million children's lives have been saved. So in terms of coverage for Gavi eligible countries that get more affordable vaccines, the coverage there is roughly about 75%. And then for non-Gavi eligible countries, it's much lower than that. So middle income countries in particular, we've got coverage there about 25% or so. So the vaccine, as I mentioned before, was licensed about 25 years ago. So most countries in the world have been using it. In grey there's some countries that still haven't used it, including Thailand and China, and Egypt in the national immunisation schedule. But this is 10 years after the US licensure. So this was in 2010, and this is looking at PCV use. You can see that it's mostly in high-income countries and a few middle-income countries at that stage. And even 15 years later, there was still not widespread use, and particularly in Asia, in larger countries, again, China and India, and particularly Southeast Asia. So there's huge delays in getting the vaccine rolled out. So the price per dose, it has gone down over the years, but it's still a considerable issue. So on the bottom axis is the average price per dose, and on the vertical axis is the income level by country. And you can see at the bottom, low-income countries and low and middle-income countries that are Gavi eligible certainly get better vaccine prices and benefit from that. And high-income countries, of course, pay the highest. And then for low and middle-income countries, so either former Gavi eligible or never Gavi eligible, you can see that there's a big price hike. So suddenly budgets need to increase by about 3 to 4 times. And in some circumstances, there's even these countries are paying more than high-income countries. So there's sort of an issue there regarding price. There are 3 different formulations that are WHO pre-qualified. The latest one is Serum Institute of India, which is a 10-valent vaccine, and this is the UNICEF prices, and the PCV made by Serum Institute is the most affordable of all the vaccines, and all are recommended through WHO, and as I said, are pre-qualified. Now, recently there was, last year, UNICEF looked at how much it cost to fully vaccinate one child. So this is based on, up to 2 years of age, those vaccines that are listed there in the box. And it costs about $73 US on average, but there's a range between $46 and $130 to vaccinate one child. And that includes the cost of the vaccine plus the delivery costs and wastage. And then we've got about half of the vaccine is the cost of the vaccine itself, and with PCV most expensive. Add 1 dose of HPV and for teenagers, and the cost increases about to the average cost of $84 per child to vaccinate. And then compared to the price has sort of gone up in the last 4 years, since 2020, by nearly $14 per child vaccinated. So costs are still, going up. And then there's new vaccines, of course, coming in. The latest, which is for Africa, is the malaria vaccine. So countries need to find an extra $56 to add 4 doses of malaria vaccine. This is also in the context, this is prior to this year when, global health funding has reduced, but even in 2023, it was found that it was an increasing funding gap for 16 countries, for 16 vaccines, sorry, for low and middle income countries, and that doesn't include RSV, COVID, or flu vaccines. So you see there in the open boxes with the red border, that's the funding gap estimated for those 16 vaccines for 94 low and middle income countries prior to this year. Now, an example of PCV optimization in Laos, so they undergo Gavi transition. They introduced PCV 13 in 2013. At the time, they introduced hospitalized acute respiratory infection carriage surveillance and have been doing that for 12 years. And found that there's no difference in the coverage for vaccine types carriage between Pneumosil and the current PCV 13, which is what they had introduced. And so they switched to a Pneumosil, which is the more affordable vaccine, and they saved over $300,000 per year. Now, recently, the WHO SAGE position paper has been updated, and because of these potential budgetary impacts, which some countries have, or constraints, I should say, countries with mature programs that have achieved high levels of herd immunity may consider one or two cost-saving strategies, and that's a reduced dose schedule of 1 prime followed by 1 booster, or a fractional dose of 40% of the 13-valent vaccine, which is the only product for which evidence supports this approach. Both strategies require high vaccination coverage and careful monitoring of coverage, with contingency plans to revert to a 3-dose schedule if indicated. So the criteria to switch to a 2-dose schedule is sustained coverage of more than 80% for 5 years, or sustained vaccine type control demonstrated through surveillance or multi-age cohort campaigns. And just to be aware that coverage within a country and at subnational level could vary. So important to look at not only national average, but also the subnational coverage, because there may be pockets that have lower coverage. Now, pneumococcal carriage is common, so that's at the back of the nose, and then that is required before invasive disease occurs. And so invasive disease being meningitis and sepsis and also pneumonia as well. And so often clinical trials use pneumococcal carriage as one of the endpoints as a proxy for disease. So if there's a decline in vaccine types, it's most likely there'll be a decline in disease as well from those vaccine types. So the evidence behind WHO's guidance, updated guidance on 3 versus 2 dose, the 1+1 schedules, was based on a systematic review of clinical trials, of which there were 8 clinical trials from around the world, including the UK, Canada, and the Gambia, South Africa, India, and some studies from Vietnam as well. Surveillance data, so UK is the only country using 1+1, and also some modelling data. The clinical trials from the systematic review found that there was a lower immune response following the primary series with 1+1 versus 3 doses, which is not surprising, but similar immunogenicity after the booster dose. There were no differences found in carriage of vaccine types after the primary series or after the booster. What the pivotal clinical trial was in the Gambia, a cluster randomized control trial. And this was done in a country which had long-standing 3-dose PCV use with high coverage. And they compared 1+1 versus the current 3+0 schedule, and they found that vaccine carriage in children with pneumonia and in the community in year 4 was similar. And also they found no differences in radiological pneumonia incidence in children under 5 as well. England, as I've mentioned, is the only country that has been using a 2-dose schedule. They switched in 2020, and they found sustained low rates of vaccine type invasive pneumococcal disease in children under 5, 5 years following that switch from a 2+1 to 1+1. So on the left is the surveillance graph of vaccine types by year, pre and post, and I've circled there for under 2s. This is up to July this year, that vaccine type control is still evident, and similarly for the 2 to 4-year-olds. So the UK has got, 5 years later, still has sustained control of vaccine types. So the questions are really, will the 1+1 schedule still provide protection between the first and second dose? And so this relies on direct protection of just after the single dose plus the indirect protection from those vaccinated with the 1+1. And when we look at, this is very important because when we look at pneumococcal meningitis age distribution before vaccine was introduced, particularly in low and middle income countries, the burden of that is much higher in younger infants. So looking back at the systematic review, looking at PCV10, so this is the meta-analysis looking at vaccine type carriage post-primary series, and it clearly favours that one dose is better than nothing at all. So it's likely there'll be some protection, and this systematic review found a 60% reduction in vaccine types, one versus nothing. And then we found no difference in one dose versus two doses in the bottom left, or one dose versus 3 doses for vaccine types, and that's for PCV10. Now, when we look at PCV13 vaccine types post-primary series, there was only one study from India. We looked at 1 versus 0 doses, and there was no difference found in vaccine type carriage. And then we looked at 1 versus 2 doses, and there was no difference either. There was 2 other studies looking at 1 dose versus 3 doses, and we found no difference in the meta-analyses. Now looking at post-18 months vaccine types, so this is a proxy for whether it'll produce indirect effects or not, because toddlers are the main age group to transmit to other age groups. And so if there's similar reductions in vaccine types in the second year of life, we can assume that there will be similar indirect protects generated. So this is PCV10 vaccine types in that at 18 months, so after the final dose. And this is 1+1 versus 0 and doses, and so it clearly favours 2 doses versus nothing. And then this, we found no difference in 1+1 versus 2+1, or 1+1 versus 3+0 in the meta-analyses. Now looking at PCV13, again at the same time point, vaccine time carriage at 18 months post-final dose, only one study at 2 dose versus 0, and we found that there was a 35% reduction in vaccine types in the 2-dose schedule, and we found no difference in 1+1 versus 2+1, or 1+1 versus 3+0. Now, coming back to the IPD surveillance from the UK, which they adopted 5 years ago, this is looking at children, the surveillance over time in children between 4 and 12 months of age, so between the first and the second dose, and they found no indication of any increase in disease in that time period. And so in the there's also been a systematic review that's been subsequently published looking at the vaccine effectiveness of a single dose against vaccine type invasive pneumococcal disease, and found that 1 dose of PCV provides protection against vaccine type IPD, especially after 12 months. So this is PCV10, fewer studies, only 3. The age under 5 wasn't specified, but after a single dose, there was about 73% vaccine effectiveness. More studies for PCV13 for infants, so less than 12 months of vaccine effectiveness found of 56%, and then for infants, children over 12 months, about an 80% vaccine effectiveness following a single dose. Now, the second question is, do reduced dose schedules still provide indirect effects for infants too young to be vaccinated, so before they've received any doses at all? And so this relies completely on indirect protection from those vaccinated with 1 prime plus 1 boost. And so for vaccine type, for indirect protection to occur, so infant immunisation confers indirect protection against vaccine type invasive pneumococcal disease. And for when this meta-analysis was done in 2017, PCV7, so the 7-valent vaccine was looked at, and looking at children under 5 who are unvaccinated, it took about 2.5 years to attain a 50% reduction in invasive disease for children who are not vaccinated, so indirect effects to appear. and it took about 9 years for about a 90% reduction. And for the 13 valent only serotypes, that pattern was similar, but there was no data from low-income countries, and only 4 low and middle-income countries were included in this meta-analysis. Coming back again to the invasive disease surveillance from the UK, which adopted this schedule in 2020, looking at infants too young to be vaccinated. Again, no indication of any change in disease burden over the period following the switch. So an example of optimizing the PCV schedule in Fiji, I will give here. So they changed to Pneumosil. They introduced the vaccine in 2013. They changed to Pneumosil in 2018 with the most affordable vaccine with substantial budget savings. And they're now considering a switch to a 2-dose schedule. And so the data that they put together to make that decision is they looked at their coverage over the last 5 years and found that that it was more than 90%. Vaccine serotypes in under 5. There was low rates of vaccine types in carriage. Less than 3%. 3 years after the vaccine was introduced, and then the most recent data on IPD showed low rates of vaccine types. Modelling was done to predict the impact of vaccine type carriage and disease, and found similar suppression of vaccine types with a 3-dose versus a 1+1. There was a substantial budget savings when given with the first dose of MMR vaccine, and also it was cost effective a 2-dose schedule if the second dose was also given with the MMR vaccine. So in summary, Fiji could switch to a 2-dose schedule. They would be eligible, but absolutely essential to have ongoing serotype surveillance through invasive disease and also through carriage surveys. Looking at the Pacific Island countries, whether they would be eligible as well. The second dose, and this is the coverage of MMR at 9 months. So the second dose for the 1+1 schedule can be given at 9 or 12 months of age. So this is looking at 9-month MMR coverage. And so the countries in green there are those with high, meet the criteria based on coverage and would be sort of eligible to switch if they were interested in doing that as well. Now looking at that fractional dose schedule, so the evidence of the second option for where there's budget constraints, so a fractional dose of the 13-valent vaccine. So in Kenya, there was a randomized controlled trial, a setting program with PCV using a 3-dose schedule. Infants were randomized to one of 7 groups. They either received the 13-valent as a 2+1 schedule, as a full dose, 40% dose, or 20% dose. Others received the 10-valent GSK vaccine as a 2+1 schedule, as a 40% or 20%. And the others received the standard 3-dose schedule through GSK. And they compared immune responses and vaccine type carriage. And the findings indicated that a 40% fractional dose of PCV13 has similar immune responses versus the full dose, but was not recommended for a 20% dose of the Prevnar vaccine, or for any of the fractional dose 20 or 40% for the GSK vaccine. So looking at policy decisions, we've done some work, important that they're made through NITAGs and using a learning health system approach and health strengthening. And so this is an example of some of the work that we've been doing and supporting Lao through their Gavi transition, and how to use research into policy and then determine the impact. And it was co-designed, the project, with the ministry and the NITAG, WHO, and sort of many partners. And we strengthened 3 areas. So the National Immunisation Technical Advisory Group, using the WHO Global NITAG Network Evidence to Recommendation. So using that systematic approach of using the evidence to be able to make recommendations for immunisation policy. We also, the government has a health policy unit. And so we had training for them, as well as the NITAG, Ministry of Health and Vaccine Economics, so budget impacts and cost effectiveness analyses, looking at health technology assessment training, and also NITAIDs make recommendations, but governments actually implement them. And so then how to do the advocacy to translate evidence to policy, to convince the minister or the finance minister to actually adopt the recommendations by the NITAID. We also mapped locally the local research needed to inform policy as well. So again, all those three elements are really important to have a functional immunisation policy system using evidence in a systematic process. And we have a new project in Mongolia as well that's going to be starting next year on this, and using PCV optimization as the case study. So in summary, where there's budget constraints for optimization, switch to the lower price PCV, like many of these countries have already done. For eligible countries and settings who are eligible, so where there's more than 80% coverage for 5 years or sustained vaccine type suppression, there's the option of switching from a 3 to a 2 dose schedule, so 1 prime plus followed by 1 booster. The fractional 40% PCV13 dose, but critical if those decisions are made to maintain that coverage greater than 80% and to monitor serotypes and have a recovery plan if there's any indication of an increase. And the savings then on vaccine costs should be used to improve coverage or to consider other antigens that may be on the table. More details can be found in the WHO position paper that came out in September. And additionally, important to use evidence-based policy for NITAIDs and health economics, ensure and for the international community to have ensure vaccines are affordable. Developing country vaccine manufacturers are key. The World Society of Pediatric Infectious Diseases 2 years ago had a call to action to ask governments and international organisations to urgently develop and implement a global plan to better address access and affordability challenges for all countries with limited resources. And we have had our call to action published, and the box there just shows all the different action points that we thought different agencies should be looking at. And then we had all these agencies that are child health, key child health advocates and who represent children's interests to sign up to that. And at a recent Bangkok conference, we had a panel to discuss this further. So we'll have this ongoing conversation to make sure that everybody has access to affordable vaccines. So thank you very much. That's the end of my talk.
You're on mute. Right, I think I'm up. Katia, can you hear me?
I can hear you, Keith. I think I couldn't hear her either, but everyone can hear you, I think.
Oh, that's great. Okay, because I think the room is sort of muted. Okay, so I can start, I think. Thanks. So it's a great pleasure for me to have the opportunity to chat to you on World Pneumonia Day. I happen to be in New York and just came out of a meeting discussing future vaccines for protection of infants against pneumococcal disease. And so after that excellent talk by Fiona, I'm going to start off with some general observations about what is happening with pneumonia in children, and then specifically address the intersection between prevention of pneumococcal disease and specifically RSV. So Oh, that didn't seem to work too successfully. I'll try again. Click to exit. Oh, wait a minute. Okay, sorry, folks. That's the last slide. I see where we go. Here we go. Okay, so there we go. So pneumococcal disease is a disease, and mortality from pneumonia is a problem of the poor. And the graph on the left-hand side shows you mortality associated with pneumonia. And you will see that in the richest countries of the world, which have the highest socio-demographic index, so wealthy is on the right, poor is on the left, rich countries like the Americas, very little mortality from pneumonia, which is on the y-axis. In Africa, which is these gray bars over here, the wealthiest parents, their children have a low rate, or the lowest rate of mortality. It's still higher, much higher than the highest rates of mortality in, say, the Americas. But the poorest of the poor children, well, children of poor parents in Africa, have the highest rates of mortality. Now, one of the great public health celebrations of the last 20 years, or 30 years, in fact, is the reduction in childhood mortality. And seeing as pneumonia is an extremely important cause of childhood mortality, pneumonia deaths too have reduced by 57% in children under 5, a similar reduction in older children, although the burden of pneumonia is much lower. I will not be talking about the increasing burden of pneumonia mortality in the elderly, but although it looks bad, these are absolute numbers. And in fact, this is a reflection of people living longer. So more and more people are now living over 70 years, and pneumonia is a major cause of mortality in the elderly. If you are focused on preventing pneumonia in children, then we're looking here at the green, and the place to look is sub-Saharan Africa and South Asia, more specifically India, Pakistan, and Bangladesh, and then to a lesser extent, places like Indonesia. So that's why the Gates Foundation is focused on those areas. The mortality in gray is adult mortality, and you'll see that in fact that is the dominant form of mortality in places like the Americas. So now this is a picture of where we focus at the Gates Foundation. All of these are major causes of mortality in children, and we're interested in trying to develop a vaccine against Group B streptococcus for neonatal sepsis, E. coli, and Klebsiella for the same reason. But today I'm going to talk about the right to, that's the respiratory syncytial virus, where we are also working to make vaccine available to Gavi countries, and then the pneumococcal vaccine. Now, if you look at vaccine preventable mortality in children, the leading cause of mortality due to a vaccine preventable pathogen is pneumococcal disease. Now, I will confess that I've seen numbers varying somewhat for malaria. So if this were a malaria talk, you might see numbers higher for malaria. It's great that we have a vaccine now for malaria, but of course the efficacy is much, much lower, but a big burden of mortality, potentially preventable in malaria. But still, pneumococcal disease, the leading cause of vaccine preventable mortality. And you'll see the fourth on the list here is RSV, and I will make the argument that I think RSV mortality is undercounted. Now, everybody has their favorite slides, and this is mine. Well, this is my second favorite slide, because what it shows is in the United States in 2000, when the PCV7 vaccine was introduced, the number of cases per 100,000 of the PCV7 types, which is this green line, just the types included in the pneumococcal down. Vaccine was introduced January 2000. By the end of the year 2000, the number had come down. And you'll see that by 2005, there was a 100% reduction, complete disappearance through direct protection of young children of the 7 serotypes in PCV. But my favorite slide is this one, of course, which is not the children, it's the adults over age 65 in the United States. Here is the vaccine types included in the vaccine, the 7-valent vaccine given only to children, no vaccination of adults at all. And in the adults over age 65, the CDC surveillance shows this slower reduction. So Fiona alluded in terms of other type of herd protection, protecting young infants too young to be immunized, but similarly, that estimated about 3 years. So while the kids, the disease came right down by 2001, 2002, this has taken longer, but the herd protection was dramatic with a 92% reduction overall in vaccine type disease. Now, this is true also for PCV13, and I'm just giving an illustration here of a middle income country. So this is South Africa, and this is again adults. It basically says everybody over the age of 5, but the vast majority of these cases in South Africa are young adults, often HIV infected, and serotype 1 was the leading cause of invasive pneumococcal disease in adults with close to 400 cases per year, as you can see in 2009. Dramatic reductions, and in fact, it's completely disappeared now in children and in adults, all through herd protection. So a very important aspect of pneumococcal conjugate vaccine. Now, if we go back to 2006, this was the state of the world in 2006, and only the rich countries had the pneumococcal vaccine. Now, I'm going to show you in the next slide the wonderful rollout of pneumococcal conjugate vaccine globally. But I will tell you that the next generation vaccines, the 20-valent plus, if you look at the distribution of which countries have access to that, it will look very similar to this slide. So we have a challenge to get the next generation vaccines out there. But in the meantime, the 10 and 13-valent vaccines are dramatically rolled out now across virtually every Gavi country. You'll see there 50 out of 54 Gavi countries on the right-hand side have introduced, and the remaining 4 are planned. So within a year or two, every Gavi country, the children will have access. There's some extraordinary places, which including China, which do not yet vaccinate the entire population. It's only wealthy parents who can afford the vaccine, but the arguments are clear that this would be life-saving for children. Now, I'm going to talk mainly about the next generation vaccines, and the reason for this, which I didn't actually show you, is that the burden of pneumococcal mortality has now shifted, and it's shifted to the types that are not included in the vaccine. We fund a large surveillance campaign or study called CHAMPS, and the CHAMPS study is able to document pneumococcal serotypes causing mortality in children, and around 15% of all-cause mortality in the CHAMPS study is still due to the pneumococcus, and it's the serotypes that are not included in the 10 or 13-valent. So a 20-valent vaccine would be life-saving in Gavi countries. As I mentioned, not yet rolled out there. And there are some problems associated with it. So these are the licensure criteria of the 20-valent vaccine. And the licensure criteria, according to WHO, are 2 things. One is the immunoglobulin geometric mean concentration after the primary series. And you will see that equivalence would be 1. So this is comparing PCV20 to PCV13. And you'll see for every serotype, in fact, there's a reduction. So you pay a price of going up to more serotypes. There's a lot being written about this. There's suppression of the immune response, especially if all of the capsular types are conjugated to the same protein, in this case, CRIM protein. And although the criterion for non-inferiority, that's what this NI means, was a 50% reduction, and this basically met non-inferiority, except just perhaps for 6B, the lower bound reaching 50%. there's definitely a reduction in immunogenicity, and we don't entirely understand what that reduction means. It is clearly PCV13 was highly effective in reducing invasive disease in children and in reducing herd. Will PCV20 do the same? And we urgently need data on this. The closest data would come from the US, where the vaccine was rolled out in children 3 years ago, or certainly early 2023, but we still haven't seen any data. The other criterion WHO uses is the percentage of children whose antibodies after the primary series reach 0.35 micrograms per mil. And in the same way, you see these percentages are all lower than equivalent. So what's on the table? Well, it's very good. When you talk about 15, 20 valent, and then more than 20 valent, there are a lot of candidates on this list. And it's extremely exciting. This is a dual market, so there is an interest in having rich countries getting these vaccines as well. But we are very keen on, this is the Gates Foundation, we're very keen on funding vaccine manufacturers to make a vaccine affordable to Gavi. As yet, there are no data or nothing is licensed beyond 20 valent except for the Pfizer 20 valent vaccine. Now, Fiona talked about this, so I'm not going to dwell on it at all. These are the studies that were all funded by the Gates Foundation to make the argument that a 1+1 vaccine could be cost saving. And this is extremely important now because Gavi, who pays for vaccines for the poorest countries in the world, has a funding shortfall of $3 billion. And all of these countries and countries that are graduating from Gavi are going to have to pay for their vaccines. Well, you know, Gavi still will pay for the poorest countries, but Gavi does not have endless pots of money anymore. And so it is extremely important that we very carefully consider ways of cutting costs. And it would be great, in fact, if cutting one dose of PCV, that money could be used for another similarly priced vaccine, which is also about to roll out, and that is the RSV maternal vaccine. And so if you look at the equation that way, is it better to give 3 doses of PCV or to give 2 doses of PCV plus an RSV vaccine to pregnant women? It will protect their infants from RSV in the first 6 months of life. I'm going to make an argument that is probably a greater public health benefit than just giving the 3 doses of PCV alone and no RSV. So this is the recommendation that Fiona talked about, and so I won't be going into that in any more detail, but I'm now going to share with you some data on the interaction between pneumococcal disease and RSV. So this is the 9-valent pneumococcal conjugate vaccine trial, which I was privileged to lead this study way back. It's 25 years ago now, in the year 2000. And so what we have here are PCV9 vaccine. It says vaccines, but it's vaccinees. And there were 18,000 of them and a similar number of controls. And amongst them, there were cases of influenza or RSV. And I'm going to just draw your attention to the bottom line here, which was RSV in HIV uninfected kids, because there was some RSV in HIV infected kids where the vaccine efficacy was a little bit lower. But in HIV uninfected children, there were 64 cases of RSV-associated pneumonia and 94 in the control group. So what is happening here? How is it possible that a pneumococcal conjugate vaccine, in this case an early version of the vaccine is now available, a PCV9 vaccine, how could it prevent RSV? And the point is it doesn't prevent RSV, but it prevents RSV-associated hospitalization for pneumonia. And what it's telling us is that a large fraction of children who are hospitalized with RSV go on to be, the reason for their hospitalization is secondary pneumococcal pneumonia, which can be prevented by a pneumococcal conjugate vaccine. So the inference from these data is that these RSV-infected kids would not have been hospitalized if they didn't get the secondary pneumococcal pneumonia. And so that's a large reduction, 32% in RSV-associated pneumonia by a pneumococcal conjugate vaccine. Now, is there any effectiveness data to show this? And indeed there is. And so this study is a study that was conducted with me and a number of investigators, again, a good few years ago in the US, where we were able to model the reduction in the amount of pneumococcal pneumonia associated with RSV. And certainly in the first 2 months of life, when RSV is a major cause of hospitalization, you will see that there's again a very similar percentage of RSV that is associated with pneumococcal pneumonia. So I know that Heather Czar was going to be giving a lecture on RSV, but I believe that Heather was unable to give the lecture. And so in any way, repetition is useful. So I'm going to show you a little bit now about the burden of RSV and the very exciting vaccines, and then come back to this question of whether these RSV vaccines, as they roll out, could actually protect against pneumococcal disease. So these are sites where we at the Gates Foundation were able to fund studies to determine the fraction of pneumonia mortality in children attributable to RSV. And what they showed is that a large fraction of mortality was attributable to RSV. So we now have 2 different modalities to protect against RSV in young infants less than 6 months of age. One is a monoclonal antibody, and there are 2 versions of it here, nirsevimab and clesrovimab, and that's who makes them. These are great introductions to prevent RSV. The problem is they're far too expensive for Gavi. These vaccines cost hundreds of dollars a dose, and there is no vaccine against RSV, no monoclonal against RSV available to Gavi under $100 a dose at this time. However, through an agreement between the Gates Foundation and Pfizer, the pre-F vaccine, so this is a vaccine given to pregnant women, and then the antibodies that are generated by the mother transfer naturally to the baby. And here's the point estimate, as you can see, of efficacy, very similar to the monoclonal point estimates of efficacy for protection the first 180 days of life, first 6 months of life. And so this vaccine is in fact going to be made available to Gavi at an affordable price, and it's in the public domain that price will be less than $5 a dose, which is a wonderful public health contribution from Pfizer. And so the way this will work is that there will be a multi-dose vial that is almost WHO pre-qualified, and we at the Gates Foundation have helped fund the development of that. And then this vaccine will roll out and hopefully start to protect infants from RSV in the first 6 months of life in Gavi countries. So these are the data on direct protection of RSV lower respiratory tract infection. But notice also in all 3 of these studies, there's a 30 to 50% reduction in all-cause lower respiratory hospitalization. And that is high if you consider the RSV is only one cause of respiratory hospitalization. And I think that what we're getting here is that when you're protected against RSV, you're also protected against the subsequent pneumococcal pneumonia, which can land children in hospital. So let's have a look now at the real world impact data, the effectiveness data. And I'd have to say it is stunning, mostly in rich countries for the monoclonals on the left. And you will see effectiveness of around 80 to 90 on RSV-related hospitalization, and even higher, 90% plus in some instances, on RSV-associated intensive care hospitalization. And then similar numbers on the right-hand side, the vaccine impact on hospitalization. So what about this question then of all-cause lower respiratory tract infection? And here, the real-world data are even better than the randomized trial data. And this is showing you extraordinary impact and reductions, vaccine effectiveness in prevention of all-cause lower respiratory tract hospitalization. Now, this is all restricted to RSV season, but it is, to my view, very stunning data that would allow us to predict that the RSV maternal immunization and/or monoclonal antibody are going to work to reduce pneumococcal disease as well as RSV disease, certainly in the first 6 months of life. And there's some data suggesting that this protection could extend even to a year of life. So in summary then, what have I told you? I've told you that deaths are declining in children, but that pneumococcal pneumonia remains a major killer of children, that the pneumococcal conjugate vaccine, which had not rolled out in any developing countries in 2006, has now rolled out in all Gavi countries but 4, where it is planned to be rolled out, which is an extraordinary contribution of Gavi to saving lives of young children. That innovation in dosing schedules, which you heard about from Fiona, can reduce cost by reducing the number of vaccines from 2 to a 1+1 vaccine. But still, next generation vaccines are needed to protect against the vaccine serotypes that are still causing mortality beyond the 13-valent. That 30% of pneumococcal pneumonia first 6 months of life may be attributable to RSV. And finally, that we are supporting the introduction of a multi-dose vial to allow RSV vaccine to become the next vaccine to save lives in young children in Gavi-eligible countries. So thank you very much for your attention.
¿Aló, me escuchan? Yo no lo escucho. Okay. Good afternoon, everyone. I am Francisco Arancibia on behalf of ALAT. I appreciate this invitation. At ATS 2024, several respiratory societies of America participate in a symposium on community-acquired pneumonia in vulnerable population across America. And its conclusions were recently published in the Annal of the American Thoracic Society. In Latin America, data consistently show a high incidence of CAP. Pneumonia and respiratory health inequities disproportionately affect vulnerable populations across Latin America, particularly children and older adults with biological and social vulnerabilities. Pneumonia occurs very widely across socioeconomic, geographic, and demographic groups, reflecting in part inequities in social determinants of health and access to timely and high-quality care. Pneumonia remains among the top 5 cases of deaths in Latin America, and cat mortality ranges from 14 to 83 per 100,000. It is higher than in high-income countries. The paper proposed 3 interconnected domains where respiratory societies can contribute significantly. 1, comprehensive prevention strategies. Vaccines are the best way to prevent respiratory infection and pneumonia. We recently published the ALAT guidelines on respiratory vaccines in the journal Respirar, and we call the authorities and the public in Latin America to improve immunization coverage, especially among children, older adults, and people with high-risk chronic illness. 2, improve the recognition and risk stratification, including pneumonia care battles that link evidence-based clinical management with systematic screening for social determinants of outcome. And 3, equally access to diagnosis and treatment for this patient. Thank you for your attention.
Hola a todos. Hello and good evening. My name is Kjell Hansen. I'm the previous chair of the European Lung Foundation. And I want to thank the organizers for inviting us back to share some of our experiences, also on the collaboration in the efforts to combat pneumonia. So what is the European Lung Foundation? So basically, it is an organization that has a vision for people living with lung conditions to be fully involved in lung healthcare and research, and for everyone in Europe and beyond to have clear, reliable information that can be trusted about lung health and disease in their own language, which means that we do have a lot of information in multiple languages on our website. So ELF is special in the sense that it is a patient-led organization, and it works international to bring both patients and the public together with healthcare professionals to improve lung health and advance diagnosis, treatment, and care. So how do we do that? So first and foremost, we are working together with the European Respiratory Society, the professional organization in Europe, and we work in partnership then with them, but also with other stakeholders. And what ELF brings to the table is then that we are able to connect with people living with respiratory diseases, and we are able to find both out information about what is their concerns and also how do we address it. So one of the areas that we have been working on that also I think is related to pneumonia and to vaccinations is that we have been working on the joint statements in order to support science initiative and to push back on disinformation and political pressure, and also on the funding cuts that many organizations that are doing important work are experiencing these days. So we do have quite elaborate resources on different kind of lung diseases. You will see some of the languages in the bottom right, so including Spanish. And one of the key fact sheets that we do have to offer is on pneumonia. And we do take quite seriously also updating these pages in order to meet the current standards. And this page was latest updated also earlier this year. And it includes information then on causes, on treatment and prevention. And this, I think, is quite essential if you're operating a patient organization or a public health organization that has interest in informing public segments about these areas, also in a layman terms. So we are also working on a bigger setting, and that is within also the political, the advocacy sphere. So we are working within a coalition called the International Respiratory Coalition. And one of the initiatives that we are taking within that coalition is to develop something called the Lung Facts, where you will have data on various lung diseases and how they're experienced around the world. And here you will also see lower respiratory tract infections and what are the numbers for those. So it's easy to use that also to build a political case for change and to influence policy. And here we can also look at epidemiology and economic impact of pneumonia and what that means to specific countries and regions and so on. So one of the pushes that we are making is to have coherent respiratory diseases in as many countries as possible. And for that, this is an essential tool. We are also having quite a few public awareness campaigns where we collaborate, amongst other, with the European Respiratory Society. And here is one on vaccinations. So focus on vaccinations, including both materials and infographics. And that is also something that's free for others to use in order to build awareness and create political pressure towards lung health policies. As previous speakers have mentioned, then we are also involved in AMR, and here's from an EAS publication, also showing that the pneumonia pathogen associated with AMR is the most recognized for the respondents in this investigation, showing that we are also building this kind of understanding and awareness around what pneumonia is. With that, I would like to invite you to take action with us. And if you want to collaborate, then we do have our contact information, both in terms of the website, europeanlung.org, and the central ways of getting in touch with us. And with that, I want to thank you and wish you an enjoyable rest of the conference. Thank you so much.
Hello, everyone. I'm Raquel Duarte, Chair of the Assembly on Respiratory Infections at the European Respiratory Society. It's an honor to be here today on behalf of ERS to mark World Pneumonia. Hello. Everyone. I'm Raquel Duarte, Chair of the Assembly on Respiratory Infections at the European Respiratory Society. It's an honor to be here today on behalf of the ERS to mark remains one of the most serious and preventable respiratory diseases, and yet it continues to take lives across all ages and continents. Every year, pneumonia kills nearly 2 billion people worldwide. It is the leading infectious cause of death in children under 5, and a major threat to older adults and those living with chronic lung diseases. These numbers are not just statistics, they represent families. Pneumonia drives where access to care is limited, where prevention is neglected, and where inequities persist. As a global scientific society, the European Respiratory Society brings together experts from more than 140 countries. We work to advance research, improve prevention and treatment, and build collaboration that bridge science and policy. Through our educational programs, clinical guidelines, and advocacy efforts, ERS strives to protect lung health for all. Because pneumonia, like other respiratory infections, knows no border. But research alone is not enough. We need action. We need to promote vaccination to ensure early diagnosis and guarantee equitable access to care, particularly for those most vulnerable. We need to support research that informs better clinical management and help us prepare for future threats. On this World Pneumonia Day, let us remember every breath counts, every life matters. And together, researchers, clinicians, public health professionals, and policymakers, we can reduce the burden of pneumonia and protect the most vulnerable. Let's make these our collective commitment. Thank you all, and I wish you a most fruitful and inspiring meeting.
Friends, it is an honor to join today on World Pneumonia that unites on a shared commitment to end preventable deaths from pneumonia and advance health for all. On behalf of the American Thoracic Society, I bring warm greetings and strong solidarity. Pneumonia remains the leading infectious of all ages. It is preventable and treatable. The ATS believes that tackling pneumonia requires not only scientific discovery, but also collaboration, education of international respiratory societies. The ATS joins across in calling for urgent global action, expanding access to vaccines, oxygen, antibiotic countries. These joint efforts highlight that no one should die because of where they were born or what resources they have. The ATS has been at the forefront of defining global state-acquired pneumonia guidelines with IDSA that shape is as important as evidence. Organization, CDC, and regional thoracic societies to ensure a cornerstone of our international collaboration is the MeCore Global Health Program, which trains and mentors clinicians and researchers across the globe to build local research capacity and leadership in respiratory disease. This investment in people, our future global health leaders, is one of the most meaningful and sustainable ways to combat pneumonia and other lung diseases. Prevention is equally essential. The ATS strongly advocates for broad vaccine coverage, pneumococcal, influenza, COVID-19, and now RSV vaccines as key tools in reducing the global pneumonia burden. Our advocacy emphasizes not just innovation, but equitable access, ensuring that vaccines and care reach the most vulnerable communities. At the current Asia-Pacific Society of Respirology Congress, we were reminded of the power of partnership, of how societies across regions are working together to address respiratory infection, climate-related lung disease, and health inequities. ATS remains deeply committed to strengthening these collaborations, share best practices, and supporting joint education, training, and implementation science efforts. So on this World Pneumonia Day, I invite all of us, clinicians, scientists, and policy leaders, to act collectively. Let us bring together research and implementation, vaccine and access, and discovery and delivery. Let us build a world where every person, everywhere, has a right to breathe freely. The American Thoracic Society stands with you in science, in advocacy, and in hope to end pneumonia and advance global lung health for all. Thank you very much.
Okay, thank you. So, distinguished colleagues, authorities, honored guests, and friends, as we conclude this event, I want to leave you with a clear and urgent message. Today cannot end just as another ceremony. Today must become a starting point and a call to action. Pneumonia remains as a leading cause of illness and death, yet we know it's preventable, treatable, and often available. With timely diagnosis, vaccination, and strong public health strategies, the knowledge is out there. The tools exist. What we need now is collective will. As the Guatemalan Association of Pulmonology and Thoracic Surgery, we renew our commitment to prevent and education and early detection. But this mission requires all of us. We need every physician, every nurse, every student, every institution to become part of this movement, to educate, to vaccinate, to identify risk, and to guide our communities. My invitation today is simple, yet powerful. Ask yourself what you can do from your position, your service, your daily practice to help reduce the impact of pneumonia. Every conversation matters. Every vaccine matters. Every early diagnosis matters. And yes, every one of us matters. So let us turn this day into a sustained effort. Let hospital, clinics, and community centers become spaces of prevention and awareness. Let us defend access to vaccines, timely care, and dignified treatment for all. Let us lead by example, with science, with compassion, and with unity. Though we close this event, we open a renewed commitment to our patients, to these families, and to the respiratory health of Guatemala. What we do from this moment forward can and will save lives. So, on behalf of all my colleagues, thank you for your presence, your dedication, and your willingness to act. Let us continue together with determination and hope. Thank you very much.